Good morning, everyone. A very warm welcome to this BTOG Masterclass, Leading Your Lung Cancer Pathway. So I'm Matt Evison. I'm a chest consultant up in Greater Manchester. And my co-chair for today's event is Sanjay Agrawal. And it's really been Sanjay's vision to bring this masterclass together and this excellent program of speakers. The lung cancer pathway is incredibly complex, and I don't think anybody has got to the point of delivering the level of standard and speed that we all want to deliver. And so today's masterclass is all about discussing tools and ideas and inspiration, and a forum for discussion for clinicians that do this day in, day out, that are leading today, that are tomorrow's leaders. So I hope it's a really useful day's session of exploring those challenges and solutions. And it will be all the more better for lots and lots of interactive discussion, because we all face these challenges we're going to talk about today. And I think we can all be able to take things away if there's lots and lots of interaction. As I say, Sanjay's driven the idea and the format very much of this program, but it's been Dawn and Gina from BTOG that have put all the hard work into arranging it and putting this together. And I think BTOG's response to the educational needs during the pandemic and converting to these online programs has been fantastic. And so it's a huge thanks to Dawn and Gina that we're here today and we can put on events like today. I think there are a few housekeeping things just to go through. You can submit questions at any point during any of the talks, and myself and Sanjay will pick those up and put them to presenters. You don't have to wait till the end. Please do put your questions in there. If you're thinking it, then others will be thinking it as well, so do ask it. At the end, after the event, you'll be emailed to provide your feedback. We do need that feedback to make sure that the programs BTOG is delivering meets the needs of its members, and you need that to get your certificate. And we'll, for anyone that joins after this remotely, they will be able to apply for the CPD and put this into their diary. So in terms of the agenda today, it covers a really wide range of areas of what a lung cancer service looks like, benchmarking that service development, leadership, team working, governance. Really, I think all areas that cover lung cancer care in 2021. Just a quick highlight of the next BTOG webinar. It's on Wednesday, the 10th of November, 5:30 till 6:30. And on supporting patients with thoracic malignancies. So please do think about joining that. Okay, so I'm gonna go straight in and kick things off. So I'm going to be talking about a lung cancer service in 2021. So it's a really broad topic, this, and as I said, I'm a chest consultant. I work at a particular hospital in Greater Manchester, but I'm also the clinical director for lung cancer for the Cancer Alliance here. And so this topic of what is a lung cancer service, how do you deliver a lung cancer service, is something that I've been trying to approach for the last 4 years in that role. And today's talk is very much a reflection of those last 4 years and how we've tried to think about certain areas of the pathway, how we've tried to address deficiencies in different areas of the pathway. And I'm going to try and present that story. So it is really focused on work we've done in Greater Manchester. And so I have to say that different areas have different challenges depending on infrastructure and resources that can vary. So this is quite specific to our area. So do bear that in mind, that other areas may have their focus in different areas, but I think there are concepts that are generalizable and how we've approached some of the problems. So there's a lot of Greater Manchester reference in here, but I hope there is some learning. And again, as I say, it's a reflection on the journey we've been on in the last few years. Slide. So the overview is, I've thought about breaking this down into different components of the pathway and then put a little bit into each of those components. I thought for today's audience that I will focus on these first 4 areas. I have got some slides for treatment and survivorship. The time's just not enough to go through those, but I have, if there's any Q&A with reference to those, I can use those. But I've split this as prevention, early diagnosis, and that's symptomatic presentation, early diagnosis of symptomatic presentation. Lung health checks and screening is a whole different area. But the outflow from those programs is the same pathway. But so I haven't really touched on that in this talk, but I think there is relevance to the outflow of those programs. There's the front end of the pathway, and that's the really focused early part of CT reports, triaging that CT and actioning that CT. The staging pathway for those that do have suspicion of lung cancer, up to the point of MDT, and then treatment and survivorship. And throughout that process, there's a focus on faster, earlier diagnosis, high quality service, experience of care, performance monitoring. Those are things I'm going to try and pick out in those things. And I think the first 2, prevention and early diagnosis, perhaps don't often get all that much attention in terms of thinking about a lung cancer service. But I hope in some of the slides I show that they're an absolutely key part. I really believe that lung cancer services, leads of lung cancer services, have a huge responsibility in these areas. So prevention, tobacco control, as I say, I think that there's a massive area for lung cancer services to be involved in here. Next slide, please. And for lung cancer in particular, there's a absolute wealth of data about how important it is for someone to stop smoking during a lung cancer diagnosis. Their mortality is better. Survival is better if they stop smoking, with survival curves that rival any systemic therapy agent. Yet you don't see this in presidential symposiums at major lung cancer conferences as interventions that have huge differences. Risk of recurrence is reduced by stopping smoking. Risk of developing a second primary is reduced. And there's really substantial evidence for that. So treating tobacco dependency is a massive thing for us as a lung cancer service. Next slide, please. And then there's a big movement that's well beyond lung cancer at this point, and that is driven by the long-term plan that is going to commit to funding the treatment of tobacco dependency in acute care trusts. And so there's lots of work going on at the moment, and I use those words really specifically, treating tobacco dependency, because there's a huge shift away from lifestyle choice to the chronic disease of tobacco dependency or addiction that has really good medical management that we as clinicians can oversee and we can be really proactive in. And our experience in Greater Manchester has been, we, as part of the Lung Pathway Board I chair, we created a subgroup specifically for tobacco control. And one of the outputs of that is the CURE program that we developed and implemented it at the hospital I work at, and has since been rolled out across the region. And it's an inpatient tobacco dependency treatment service with proactive clinicians that are prescribing and specialist practitioners that are providing an opt-out service that visit all smokers that are admitted and offer them support at the point of admission and at the point of discharge. It's had some really successful outcomes. 1 in 5 of all smokers being abstinent 12 weeks after discharge at a very cost-effective intervention. Next slide, please. And I say that because, and I put that background in because that project has been the vehicle to then address what we do with smokers coming through the lung cancer pathway. And it's had a domino effect that we've now got a tobacco addiction guidance for all of Greater Manchester. So the GMMG is Greater Manchester Medicines Management Group, who develop guidance for primary care, secondary care to adhere to. And this is in line with the new NICE guidance that's going to be published about the effective treatments for tobacco addiction, varenicline, vaping, combination NRT. And this gives us standardized protocols. And we can take those protocols and we can implement them into specific situations like a lung cancer pathway. Next slide, please. And because we've had this service, the CURE service, the natural progression of that is we've taken the cure practitioners and we've put them in the geographical space where we run our lung cancer service. So that someone comes to our rapid program that I'm going to talk about shortly, and they're a smoker, we run an opt-out service. They need to see our specialist practitioners. We as clinicians need to be prescribing and giving brief advice so that they get an immediate consultation then and there. They leave the consultation with a prescription and they leave with a follow-up or a referral to a community service. And I think that is the optimal service delivery to maximize the chance of reaping those benefits I've talked about, mortality benefit, the risk of recurrence, risk of second primary, all of those things. So I think it's that the lung cancer service can really take some responsibility of it. That's how we've addressed it here. We started the Cure project, and that meant we've been able to provide the service in the lung cancer pathway. So it's a huge area for service leads to be thinking about and to be developing. Next slide, please. So early diagnosis. I was talking about this is about symptomatic presentation. And again, this next slide, please. It's so important, this, and I think one of the best bits of work that has been done in early diagnosis of symptomatic presentation has been the Leeds early diagnosis campaign, this huge public awareness campaign that encouraged chest X-ray uptake. And there was an 80% increase in chest X-ray uptake for people with persistent chest symptoms. But they showed the biggest stage shift in lung cancer outside of a screening trial, of an increase in stage 1 and 2, and importantly, a reduction in stage 4. Next slide, please. So when you see that, next slide, please. When you see the impact that COVID-19 had, where it just decimated the amount of chest X-rays being done, you understand now the impact that COVID is having and the awful impact we're seeing and are going to see when the National Lung Cancer Audit publishes imminently, that we've gone back 10 years in outcomes. Next slide, please. So Lung Cancer Service has the responsibility to be thinking about public awareness campaigns, enhancing early diagnosis, symptomatic presentation, chest X-ray uptake. Next slide, please. And we've done a bit of work in Greater Manchester about insight work into how do you overcome the barriers of patients presenting with persistent chest symptoms. And that kind of insight work can inform the development of a public awareness campaign that can address those insights and those barriers. Next slide, please. And we presented some of this work. We presented it at BTOG early this year, the Do It For Yourself campaign that used a DIY theme to encourage presentation. Next slide, please. And these are the campaign graphics that have run. And we know that we saw the biggest increase in referrals following the running of this campaign. I think it just goes to show the importance that lung cancer services, lung cancer alliances can have, not just thinking about the pathway, prevention, early diagnosis, massive parts of this and massive parts for service leads. I think a lung cancer service in 2021 focuses on those areas. Next slide, please. I think primary care education is a massively important area as well. This is some of the work that Gateway C have done in Greater Manchester, an A to G infographic for primary care clinicians with just simple reminders about false negative rate of a chest X-ray, 25%. Never forget, never smokers. 8th commonest cause of cancer deaths, lung cancer in never smokers, those that have smoked less than 100 cigarettes in their entire life. And so we're addressing the chest X-rays referrals through primary care education. Next slide, please. So moving on to the pathway, so the front end of the pathway. And this is really an area I think that every single hospital, every single lung cancer service can do a huge amount of work in. Next slide, please. Because the simple process of getting someone into a CT scanner where there's a suspicion of lung cancer, getting that CT reported and getting them in front of a clinician to act on that CT can take a significant amount of time. And when we then know that there's a complex series of tests, capacity issues with treatment further down the line, the more you can maximize that front part of the pathway, the better. And so we've talked for years now about the RAPID program that we've run with Ensure that offers ring-fence CT slots every day of the week from 8 till 9 o'clock in the morning, because it's a period of the time where those CT scanners are not doing much work. And that we've set up the service so that those CT scans are hot reported at the time. There's a radiology review on the table, so someone can have a low-dose CT scan, and if there's no evidence of cancer, they can be taken off the table. But if they need contrast and staging, the decision can be made then and there. They're hot reported, and so that patient gets off the CT scanner bed, wanders down to our Rapid Hub, where they get in front of a clinician who's triaged that CT scan and made a plan of what to do with it. Simple things. We're doing the same number of CT scans, same number of reports, same number of outpatient clinics, but it's just aligned into a next day ethos. And we've been able to show that the difference that makes from now getting over 50% of our patients from the point of referral, and including what the impact of weekends, to in front of a clinician with a reported CT scan to 3 days. And a median of 3 days. And that just takes out some of the immediate efficiencies for what is coming later in the pathway. And for the 3/4 of people that don't have lung cancer on that pathway, our patients used to wait an average of 6 days. The result is there, but they waited unknowing, worrying that they've got cancer for an average of 6 days without being told. And we take that away. Next slide, please. I think that early part of the pathway is the focus for all trusts, because everybody can deliver that. And there could be things for the future about remote reporting that facilitates this in terms of economies of scale of radiology. The staging pathway. So we've got someone, they've had a reported CT scan. They're in front of a clinician in a clinic room. There's a suspicion of lung cancer. We've now got to try and as efficiently as possible, get them through a rapid diagnostic and staging pathway and get them to an MDT. Next slide, please. I think there's lots of ways that this needs to be addressed. And this is just one example of the test bundles or algorithms that we put together, depending on the pattern of disease on CT. So that if you have this pattern, so what I'm showing here is either a central tumor or N1 lymphadenopathy, there is a series of tests that patient needs, and that can be easily defined. They need a PET, they need a staging EBUS, they need contrast-enhanced brain, stage 2, nice guidance. They need a standardized set of physiology, and they can be created into test bundles. So we're sat in front of a patient and we say, right, you need 5 tests. And we know what we're doing, and we can, and we immediately have got a plan. And these diagnostic bundles have now gone as a national document. They're called Standards of Care, and they support the National Optimal Pathway. Next slide, please. But then how do we deliver that test bundle? We've approached it as so there are some tests that are always going to be done at our hospital, and we need access to them. So we need ring-fence slots. And the things we looked at were lung function, echo, and MR brains. It's where we struggled. So we sat the managers down and CDs down of these areas and said, lung cancer pathway, massive problem, biggest cause of premature mortality in our region, delayed pathways, harm, biologically very aggressive cancer. Set the scene. Say, right, we need ring-fence slots from you. I made an estimation of the number we need and agreed a number of ring-fence slots, how we would book into them. There was always concern back about, well, what if then that slot doesn't happen? We've wasted it for someone else. So we had to make pre-arranged agreements about when those slots, if they're not utilized, when they'd go. And so we've had a look at this, about the impact of it. We looked at it for the 3 months beforehand and the 3 months afterwards. And it does make little differences, little incremental gains. One of the biggest things for us, though, is that we've maintained a pathway despite a significantly escalating number. And we're all seeing this, and we've got big screening programs coming online, so the volume of traffic through our pathways is increasing. And these ring-fence slot has allowed an escalating volume and maintaining that, and equally some improvements over time. But we'd want more from this, and I think there's more work to be done on this. A simple thing we've encountered is that we can't book into a ring-fenced MR slot until the request has been vetted by a radiologist. And if that vetting process isn't done immediately, we lose the whole point of this ring fencing. So we're now protocolizing vetting so it doesn't have to happen. Simple things like this. These are logistical things. But this is how lung cancer services work. And I really believe this is how what the future is. Because when that patient's sat in clinic, we want to say, right, you're having your lung function on this day. And we can work it so your echo's on the same day and your MR scans on this day. Next slide, please. But then there are tests that are not individual hospitals. There are tests that have to be looked at on a regional scale. I think one of the things that has been a really good thing in our region has been the performance monitoring process we've done for eBus. Every eBus service across the region has come together now for the best part of 8 years to collect data together and perform and quality assure our services. And there is now a national quality, there is a national service specification for eBus, a lot of it which based on that work. And these are the quality indicators that are in that national service spec. And we've been measuring ourselves against that. Next slide. And we've been able to show, so over that time period when we've been doing this quality assurance, performance improves, and particularly where there were services that had issues with performance. Over time, you can highlight issues with performance, you can put interventions in place, and you can track the improvement that happens. And you can see centres getting more and more skilled, because the best marker of that is the prevalence of N2 and 3, because you can see that going down, which means you're staging harder and harder scenarios where the prevalence of N2 and 3 is lower and lower, yet performance goes up. And that's a great thing. But the area where we've had real issues is in access. Next part, please. Next slide. We have struggled to hit that target of that's set out in the National Service Specification of an eBus within 7 days. Next slide, please. And we did a bit of work about capacity and utilization. And we have some capacity, but the utilization is not good. Some services running at maximal capacity, others have much more capacity, but it isn't being utilized. Next slide, please. So this lends itself absolutely perfectly to a single queue ethos. And we've been running a pilot recently. And the whole drive behind this is that you have to have a single booking system for eBus in our region. And you change the emphasis of the provider overseeing booking. So we get a referral, we'll decide when we book it, we'll let you know. Shift that entirely. The referrer picks the booking slot. And that means they can have a patient in front of them, day of their CT scan, and say, right, you're going to have your eBus on Tuesday. Or well, no, what they will say is, we can do your eBus, but it will be at this hospital. We could do that on Tuesday. Or if you wanted to go somewhere, the closest place to home, we wait till Friday. What would you like to do? An eBus is a bit complex, so it needs, is it staging, is it diagnostic? Do they have to have a PET first, in line with NICE guidance, anticoagulation? So you have to build a system that incorporates those rules and then allows you to book the next available test when those rules have been completed. So we procured Infoflex to do this and have been running a pilot in the region. Next slide, please. I'm going to show you, there's a bit of early data that's coming from it. It's been running about probably 4 or 5 months now. And this initial data analysis shows that there's been a 12-day improvement in waiting times. So the average wait at the moment is, it varies, but it's about 2 to 7 days through the single queue process, and that's across the system. Next slide, please. This is just a snapshot of that, of the booking system, and just one part of it. But you can see it just highlights some of these rules. So the referrer has to say, right, does this person need a PET before the eBus? Okay, what date is the PET? So that means the earliest possible date you can have your rebus is the next day. So you then search and it will give you a list of the appointments from that earliest day. So you can look, right, an e-bus is available the next day at this place and the following day at this place, or in 5 days' time at this place. And sat with the patient, right, when do you want to do this? How can you travel? How is it? How's this going to work for you? Patient choice drives it, but it's the next available appointment in line with that choice. Next slide, please. And we've been doing a bit of patient experience data because the worry is people don't want to travel. They're going to move around the region. So far, it's small numbers, but this is saying that people want to get the test as quickly as possible, regardless of travel. As long as you oversee that travel well, we've got to oversee it. The provider has to own it. So we get a referral, right, someone from the opposite side of the region needs to come here, but we're going to oversee that, not hospital transport. We'll book the taxi. It's part of our service that we provide. And this data supports that, and we're getting good feedback from it. It's early days, but I am convinced that this is the future of specialist diagnostics that cannot be done at every single hospital. Next slide, please. And PET, that automatically means patients sat in that room, we need to be saying to them, right, you need 5 tests. I've got ring fence slots at our hospital for these tests. You've got to have a PET before your rebus. So what we've been trying to work on this as well, and it's hard, but the first thing we've done with PET is a direct telephone booking. There is some issues about, you've got to be really careful with PET. You can waste tracer if someone doesn't turn up for an appointment. So everyone is very twitched about that. And we've got to understand patients' needs. So there is a specific set of criteria that is needed to make a direct telephone booking. But again, patients sat in a room, we say, right, you need these 5 tests. I'm going to pick up the phone to the PET team. And whilst you're here with me, I'm going to talk you through it. Right. Are you diabetic? Are you claustrophobic? Do you need transport? Right. The next available we can offer you is at this place at this time. Can you do that? Yes. Right. Yes. We'll book that in. And then we put the online request in. Right. You need an e-bus after that test. So I'm going to go on to Infoflex and I'm going to look, right, after we know the PET dates, I'm going to put that in. So next, I know you need your e-bus. Can you do this date? It's a logistical difficulty for the navigators doing that. It can take a lot of time, but the benefit, massive. It's absolutely huge. And again, I'm convinced this is the future, and I think we'll get better at it as time goes on. Next slide, please. Reflex testing, I think, is massively important for a pathway. We've had to do work because we had real variability in this. We have not reached the point where every lung cancer test gets reflex tested. We're just not there. But we have agreed a regional protocol that mandates a minimum data set so that stage 3 and 4 gets reflex tested across the patch, and certain samples. So if you've got a pleural fluid and it's got lung cancer in, it is stage 4. So it gets reflex tested. You don't need that information with it. And we've said that for anything that says stage 3 or 4 on it, anything that comes from e-bus, anything that comes from a metastatic site gets reflex tested. And I think this is an important thing. Next slide, please. Through this process, prehab, massively important part. We've got the Prehab for Cancer program. I think, again, it's an area that may not come as an immediate thought when you're thinking about lung cancer services. We have to have these services. They're so important. Massive meta-analysis published in Thorax last month. 50% reduction in post-operative complications from a prehab service. We know it works. It's all about implementation now. The way we've approached this in Greater Manchester is aligning with the community leisure centre. So GM Active is a collective of 12 organisations that have 87 facilities across the region. That means we can access all of those through this Prehab for Cancer program, transformation funding from the Cancer Alliance. You know, the Cancer Alliance funded Prehab for Cancer and it funded Cure. To their great credit, put the biggest amount of funding into prehab and prevention in tobacco control. I think that's what Cancer Alliances need to do. So we have a program now. We can refer, initially it was surgical patients. Now it is anyone having radical treatment. We hope to open it up even further in the future, and people will get rapid access. They're assessed, they're given a program, and they can get prehab. Next slide, please. We've published a bit of data on this at the BTS recently, showing that you can improve things, you can get people fitter, you can improve quality of life. Next slide, please. And this is just the pathway we use. I think in the interest of time, I will move on. Next slide, please. So optimal diagnostic and staging pathways, test bundles. You've got a patient who's just had a hot reported CT scan. This is where we need to be going. Sat in front of you, I've got your report. Right, I know what we need to do. If you're a smoker, you're seeing the cure team when you leave here. And you're gonna spend about half an hour with our navigator, and you're gonna leave with a diary that says your lung function and your echo here with us on this day. You're going for your PET on this time. You're going for your EBUS. Remember, we talked about you're happy to travel to that hospital to go and have it. And the samples from it are going to be reflex tested. And we go to MDT. I think that is the way we get to the optimal pathway. We're still a long way from it. You know, these are a lot of the things we're doing a pilot phase. We've got to move to the expansion. So these are regional things. I'm convinced that single Q needs to be in lung biopsy as well. It's even more complex than EBUS because of the different difficulty levels of biopsies, different levels of skills. Where can you go to have those things done? But I'm convinced that it's the future. And that so lung cancer services, priority number one, get the front end of the pathway sorted with a rapid type program. The solutions for many of the diagnostic tests are regional, and cancer alliances have to take the oversight for that. Next slide, please. Through all of this, experience of care is massively important. Our patients in our region, our user representatives that work on our pathway board, have developed a bespoke experience of care survey. It's called the Safe 7, because they created the concept that the ultimate part of experience of care is that they feel safe in our care. And there are certain pillars to that. Our patients designed this. And this is something we're starting to pilot as a survey that can be used at points throughout the cancer pathway. Next slide, please. So that's the overview. I've not gone into treatment and survivorship. There are things that can be done there as well, and things we're doing there. But I think for today's audience, we've focused on those areas. We have to think about prevention and early diagnosis. They're important. It is our responsibility. I truly believe that. Front end of the pathway, every single hospital needs to be thinking and addressing this. And the staging pathway, there are ways of addressing the complexity. We're in the really early stages of that, but I think it gives a really good idea of what the future looks like for that. Next slide, please. So I'm going to leave it there, and happy to take any questions that have come through. So I'm just going to flick across to our Q&A section. So just to read out a few comments. Great to see the treatment of smokers embedded in your pathway. Couldn't agree more. Absolutely. It's so important. Just on so many levels. It's so important for a lung cancer patient. So important. But it's such a bigger thing than that. But lung cancer clinicians, they have so many skills that are so good in tobacco control. The discussion with a smoker, it needs a level of communication skills, and lung cancer clinicians are so good at that it marries up so well. I think they're just the perfect teams to be taking this on in the pathway and often even beyond it. For the hospital, a hospital needs leaders in this area at this moment, and I think lung cancer clinicians can be that. So we've had a question: how do you ensure the PET scans are reported pre-EBUS and that the images are available? Great question. It's hard. You can't guarantee it. We've just had to set that system up that in Infoflex, the day you're eligible for an EBUS is the next day after a PET, because the reporting's variable. We're lucky because we've got Greater Manchester Sectra, which is a regional PAC system, and everybody now is joining it. There's only one or two that aren't there now. So we can access the PET scans reliably. We can do. But the report isn't always there, so we're left looking at that. So it's a problem. We want to, as part of the PET work towards hot reporting. It's hard, but that should be the goal. It should be everybody's goal. So the question is, how hard is it to get normally competing trusts to come together as Greater Manchester and tackle the blockades? It's hard. It's really hard. We've not, I wouldn't want to give the impression that we've achieved it. We have ongoing difficulties. Just to give you an example, the single queue is hard. Some, I guess I have to be cautious what I say. Some teams have really set pathways and want to send their patients certain places for their tests. It's hard to overcome that you can go anywhere for your test. What I think will happen is the data we're showing will show that it works. And then we need the system to take out clinical teams' preference in that and say, this is how we're delivering it at a regional level. So I don't have all the answers to it. We're still facing difficulties, but we have to show data that it works. That's what drives things. What proportion of EBUS at your centre are performed before PET? And if waiting times mismatch capacity? Yeah, you're right. We do EBUS before PET. But we leave that decision in the choice of the referrer. And that's how that system has to work. So they have to say, is it mandatory that this person has a PET before their EBUS? And if they say yes, we'll wait for it. And the system won't let them book it until that PET's done. But if they say, do you know what? No, they need a staging EBUS. I'm happy for you to crack on with it. And then we'll do that. And until we've aligned the two, it will just have to work like that. Question about, was there any concern about encouraging vaping? Yes, there always is. I could talk for hours on it. Yes, but you just have to overcome them with evidence base. And it's massive. I can't go through it all now, but you just have to tackle it. You have to have a great comms package and education package. So yeah, it's there's just polarized views, but personally, I am convinced they are one of the key components of a truly smoke-free generation. And I think that's just a fact. And the last question was, how have you managed workforce shortages across different departments and stakeholders? Again, with difficulty. You have to maximize where your assets are. One of the things at my own centre, we've benefited from is having a really collaborative single unit of thoracic oncology medicine and thoracic oncology surgery. We're one directorate. So we're not in a medicine directorate, we're in a lung cancer and thoracic surgery directorate. So that means, lots of clinicians in both of those areas, but we have a specialist nurses workforce and navigators that can actually work and cross cover across the entire patch. So that when we say, right, we're going to have a lot more work from this single queue EBUS because it generates duplication and hard work. Well, actually, we can cross cover this from these teams. Other places aren't as fortunate as that, but it means we've built in big capacity in certain areas of the system, but you have to maximize that capacity, and single queue allows you to do that, and everyone has to get involved in that. Right, I think I'm going to just end there because we started a little late, but I think I do want to get over to Liz, so she's got enough time for a really important talk and has time for questions as well. So Liz Toy is our next speaker, who's a clinical oncologist in the Somerset NHS Foundation Trust. But actually, many of you will know Liz because of her work in the National Clinical Expert Group, but particularly as the clinical lead for the National Lung Cancer GIRFT team. And we are all, as a pathway board chair, we are waiting for the national report. It's going to be so powerful and impactful, and it's going to be a massive vehicle for us continuing to try and change and evolve. And that, I think, it's just such an important bit of work. So Liz is the ideal person to talk about benchmarking and data through all of that work. So welcome, Liz, and thanks for talking.
Well, thanks very much for that introduction, Matt. And yes, we're all looking forward to the introduction of the launch of the national report. Unfortunately, it's under embargo at the moment, so I'm not going to be specifically referencing it, although obviously I'll be sharing some insights. When I was first given the topic of benchmarking, I thought, well, we do this all the time in cancer, in medicine. We often think of this as being, I've forgotten the declarations of interest. We often think of benchmarking as being a process where we're comparing our practice against an external standard. But I think the more we think about it, we should be thinking about it as a tool that we can use to facilitate change. We know that external facilitators, such as a GERF group, may come in to help use benchmarking data to motivate a team to engage in improvement work and understand where their performance sits in comparison to others. It may be higher, or in some cases it may be lower. And there are very few areas that we visited where everything has been good, and likewise, even in some other trusts which may have been struggling a little bit, there's nearly always some aspect of good practice which can be shared. Now, as clinicians, we can be a bit of a competitive bunch, but I think the key thing that we think about with benchmarking is that it's a reflective process. And I think this particular quote really sums up where we should be thinking of benchmarking, in terms of it's the practice of being humble enough to admit that someone else is better at something, and being wise enough to learn how to match and even surpass them at it. So historically, benchmarking was developed in industry, and largely it came about as a sort of competitive process against both analysis and cost and industrial processes. And it was particularly championed by organisations such as around Xerox, but in the 90s it became adapted to become much more of a continuous quality improvement approach, where they started to share best practice, and subsequently there was a focus on comparative measures which were of interest to the users, which in our case would be our patients and their families. And there were a number of tools that were published, such as this one by Picciarelli and Monnier, which still remains one of the most widely used tools in benchmarking. And they describe a stepwise approach which, although it identifies the competitive gap, it really emphasises that it is just one step. Equally important is at the top of that process identifying the standards, collecting accurate data, and then, having identified the gaps, communicating well, developing as a team the action plan that's going to be carried out by all. And we need all stakeholders to be involved in that. And I think, leading on from that, it needs that concrete action to be taken, but continually monitoring the process and the change that is being made. Now, again, this was still very much based in industry, but Ellis really took this forward in the healthcare sector, and in the early 2000s and subsequently she's published on it in the nursing literature particularly. They brought the practice into the clinical situation, into everyday practice, that of small things in a clinical environment, what would happen on a ward, what would happen in an outpatient area. And what she really emphasised was the importance of contemporary and accurate data to inform that continuous improvement. And as a result of that, we know that there needs to be sustained effort to continually measure outcome. And we've seen that being embedded in NHS practice. We see it in all the NICE quality standards, as an example. So in practice, we are regularly comparing indicators that we look at outcomes often. But actually, as Matt described in his very eloquent talk, we're often looking at what the structures are in place. Can we do something on a wider scale, such as he's described in Greater Manchester? Which activities are being done in which hospital? So is everywhere doing EBUS, and is everywhere doing the same sort of EBUS? One of the key things I think is important, though, is the learning that comes from inter-organisational visits. And when GERF was set up, we were very much expecting to be visiting each MDT and having a conversation around a table with individual clinicians. Sadly, COVID has put pay to that. But it's that process of continually seeking out new approaches to make those improvements. And as Matt's described in terms of his constant data collection, the monitoring and reporting of indicators, and building on that. Now, obviously, in lung cancer, for some time we have had international, national and local examples of benchmarking. And I think we must really give credit to the International Cancer Benchmarking Partnership. And we know some of our leaders in cancer, Jem Rambas and Mick Peake, have been very integral to that group. It's basically a group of both clinicians and academics, but importantly also the policymakers. This is looking on a global scale. It's looking at how different jurisdictions, practices and policies impact on cancer survival. And the partnership's own objectives are to identify specific causes of performance differences between countries where the quality is good, with strong cancer registries. They're looking at insights to generate survival outcomes, but also they're developing various tools to investigate or to simulate how a process change in one country based on the good practice from another may impact. And it's really good to hear that one of the things they're focusing on at the moment is early intervention in those patients with advanced stage disease, where we know if we're struggling maybe with our own process of getting molecular turnaround times, patients are progressing during that time. And there are a number of other European partners who have shown good improvements in their own pathways. Certainly the Danish data, where they were benchmarking internally, particularly with regard to surgical centres, by centralising some of that surgery and restructuring the way their cancer services worked. They've shortened pathway times, they've got more accurate pathology, and they've had higher resection rates. Using another example from industry, the Norwegians looked at what was known as the Toyota Lean method of trying to gain those small incremental gains in pathway times, and their overall pathway has been shortened quite dramatically. Moving closer to home, Noel O'Rourke and Robert Milroy from Glasgow have been involved in the Advance 1 study, which was published earlier this year in lung cancer. This was a European Respiratory Society funded pilot project, which really had 3 parts to it. 2 cancer centres in Glasgow and Berlin drove this, and they had firstly a narrative literature search. And in that they found, actually sadly, there's relatively limited quality and quantity of published data of benchmarking in lung cancer. Their second phase was to adapt the stepwise approach that Pitarelli and Monnier showed, the one I showed earlier, in order to develop tools to give a snapshot of their services. They looked at the infrastructure and the capacity at each site. And they looked not only at service provision, they looked at registry data, but importantly they looked at the patient experience along that pathway, and also staff satisfaction. And the output is really quite exciting in terms of the study design, which hopefully will be launched in a pan-European study in time to come. But I just wanted to look at what the individual MDT's learning was, and this is taken from their paper. The 2 centres spent time in each other's centres, observing, talking, and really developed a number of learning points, both from applicable at a local level, such as, for instance, one of the centres noticed or learned from their counterpart that working up patients as inpatients really sped up their process. They learnt the value of prehabilitation and regular MDTs twice a week rather than just once a week. But likewise, they discovered some national level or nationally applicable patterns that were emerging, such as having dedicated lung cancer respiratory physicians rather than people trying to cover maybe 3 or 4 different subspecializations within their practice. But it wasn't all learning in one direction. The second centre really learned a lot about utilising administrative staff, utilising a cancer tracker and navigator to make sure patients are kept on track, and really seeing the value of things like integrated IT systems. Matt's described the widespread PACS in Greater Manchester, but being able to share information allows a much more quick and streamlined pattern. And once again, it needs to be backed up by that regular feedback to data management. As clinicians, we are all aware of that big data, which sadly shows that when benchmarked against our international counterparts, our outcomes have been less good. And yet we do, and over time, thanks to the work of numerous people, many of whom are probably on this call, we have a lot of evidence for the variation across the UK in outcomes. We're fortunate to have the great repository of the National Lung Cancer Audit, which up until recently has shown good improvement stepwise through utilising that benchmarking against local centres and against national centres. But we also have intelligence from at CCG level, so even drilled down from individual providers at secondary care level. And we're really grateful to teams like the UK Lung Cancer Coalition and CRUK as organisations for highlighting the disparity in care. And it was because of a number of those reports were impacting at national level that NHS England approached GERFT, who had a track record in benchmarking, to look particularly at the lung cancer pathway. Now obviously our pathway was a little bit different because it wasn't simply GERFT sponsored, it was co-sponsored by NHS England. But utilising the stepping stones of GERFT in terms of gathering data, local visits where we engage with clinical teams, have clinical conversations, with engagement of the managers and implementation teams to try to enact those local action plans and to share good practice particularly. Initially our scope was to look at the unwarranted variation at the beginning of the pathway, and Matt has very eloquently described a number of the things that they were doing in Manchester, which has really been an exemplar in many of our visits going through. We built into this spec were the standards of care, which he has also referred to in terms of benchmarking which steps should occur as well as at what time points. And it was very important that it was done alongside the commissioning guidance in terms of people understanding what was actually commissioned, which might sound obvious, but actually there were certain areas, for instance, looking at enhanced supportive care, that was a very varied interpretation of. It was felt to be important that we didn't simply look at the diagnostic part of the pathway, but it was extended to look at some treatment parameters such as surgical rates and also the radical radiotherapy for early stage disease. As clinical leads, we really felt that this was a once in a lifetime opportunity really to explore some of the quality issues, and therefore we brought into the questionnaire component, rather than it being in the data packs, some of those quality standards, drawing on the information that comes from things like consensus guidance from the Royal College of Radiologists, the service specification that Matt alluded to for EBUS. And we use that information during the deep dives in terms of having that conversation and in terms of advising on some of the local action plans. And it will be within the narrative of the national report, but because a number of the questionnaires were filled in by maybe not a whole MDT, we felt there was sometimes some inconsistency, and therefore we won't be publishing it as comparator data within an academic paper. In terms of our time points, we very much drew up on the National Optimal Lung Cancer Pathway, which is obviously the commissioned pathway. Rather than mapping out the whole pathway, which is always difficult, I've just put out this simplified version from the UKLCC publication. But again, that focus on time to X-ray, time to CT from initial X-ray, the time to triage, all those aspects are so important if we are going to get patients to treatment as soon as possible, and certainly within 49 days. And I'm just going to use one real slide from the diagnostic component, and it was actually great that Matt highlighted what they've been doing with the RAPID programme in Manchester. This is just one slide which shows the variation taken trust by trust in those trusts that gave us data from their own cancer systems in the time from a patient having a chest X-ray to having the CT scan. The red line that you see running horizontally is the National Optimal Lung Cancer Plan Pathway Standard of 3 days. And we can see what a challenge there is to us, because hardly any trusts are actually achieving that. And in many cases, their median time was over 3 weeks in order to achieve that CT scan. Now, what reasons did we come across? Well, many of you will think some of these reasons are quite obvious. We're all aware of workforce shortages. We're all aware of the relative lack of CT scanners in the UK compared to some of our European counterparts. But actually, where benchmarking can come in and be really helpful is if we look at single points of failure in a service, we look at inequity of resource. Many trusts hadn't been able to employ a navigator, which, as Matt's demonstrated in Manchester, is invaluable to running that pathway. But we were also seeing variation in approach to the use of IV contrast because of local rules regarding EGFR, whether they were having point of care testing, whether it was done on a physiological basis. But also, we were seeing things like ethical arguments about equity of access. Why should a lung cancer patient have priority over a prostate cancer patient? Was an argument we heard in more than one trust we visited. Now, as clinicians, we know the reasons for that. And as Matt said, we're not often talking about more scans, we're just talking about more timely scans and then being reported at that point. And ring fencing is absolutely key to achieving that on our pathway. We also witnessed a fair degree in some trusts of being just unwilling to change approach because we've done it this way, it works, but actually our trust is special, we can't do that. And that is one of the areas where benchmarking really does change people's approach to treatment, when it can be seen that they can be confident because other areas can share best practice. Two examples of that would be in terms of the discussion around skill mix with reporting radiographers and extended nursing roles, and also perceptions of patient preference. We've seen very eloquently described in the local presentations at BTOG and nationally examples of patients having virtual consultations and being sped through the pathway. Yet we still hear how our patients wouldn't like that. But actually, when we can share the patient feedback on that experience, it's really valuable in improving patients' journeys. Another variable that we saw a lot of difference in was the proportion of patients having EBUS. Now, it's quite hard to define a standard, so we can't set a benchmark of 25% of people should have EBUS, because with it, we know that the stage distribution varies around the country. But having a discussion with a local team when we present the data, which they may not have seen against their comparators, about how many patients are having EBUS, makes them query, are we actually using the bundles of care in the way in which they are designed to be interpreted to standardise the approach for a patient with a particular stage of cancer. And likewise, what about patients having more than one biopsy? Needless to say, we need patients to have more than one biopsy if we're going to be accurately staging them. So we wouldn't expect that level to be 0, but likewise, we wouldn't be expecting it to be over 20% in a number of centres. We can't define what that correct standard is, but one of the things we encourage teams to do is to look at their decision making, to check that they are utilising that resource, which is precious, of radiologist time, of physician time in terms of EBUS, but likewise patient time and patient risk. So they're not having a CT guided biopsy if they're going to need an EBUS, with all the additional burden that brings. So what would be the impact of us actually managing to bring up the rate of treatments to a set benchmark? So one of the things, this is just data taken from the 2017 audit, but we looked at that across the patch to say, well, actually, we know there's variation. So what would happen if we brought all trusts up to the average rate of radical treatments. Well, that would actually give an extra 5% of patients being able to have radical treatment. And if we bring trusts up to the top quartile, that would be 9%, over 500 patients being able to have radical treatment for early stage disease. And we see very similar things with small cell cancer. We see the rates of chemotherapy are very variable. We also saw the speed at which patients were getting chemotherapy was very variable. And if we apply that going up to the median amount of chemotherapy being given, there's a 5% increase. And if we get to that top quartile, 10% more patients are accessing active treatment. And these are data which all trusts have in their own domain. They can look locally against their partners, but by examining the pathway, really look to see whether their decision making is in keeping with others. There are a number of areas we didn't have access to look at within the GIRF reviews. And these are some personal views, not necessarily what we've documented in the report, which, as I say, is obviously embargoed. But areas I feel would benefit from benchmarking would include, and it was interesting that Matt has already talked about benchmarking against the national specification of EBUS and how that has brought up quality improvement in Greater Manchester. We hear a lot about pathology turnaround times, and particularly with the move to the genomic hubs, that's thrown everything up in the air in a number of areas. So it's going to be important that we collect that data in a contemporaneous way and look at how that data is used in terms of access to the targeted therapies. And we know a number of areas are going down the route of regional MDTs to standardise the approach of offering targeted therapies to patients with certain mutations, opening up access to clinical trials in areas where there's smaller numbers who potentially could benefit. But I just really wanted to finish particularly looking at stage 3 disease, the role of combined modality therapy. And we know from the DZ publication back in 2019 what variation there is in stage 3 disease, with a third of patients having no active treatment at all, and only 40% getting curative treatment, with only 1 in 5 patients getting multimodality therapy. We also, as an oncologist, recognise that concurrent chemoradiotherapy is very variably used around the UK. Now, that shouldn't really surprise us when we look at the use of radical radiotherapy in earlier stage disease, and we can see great disparities in how patients are selected, with some centres having very high rates and yet other areas really treating very few patients. Now, some might argue, well, is that just because the patients are all undergoing surgery? And yet, actually, if you look at the correlation, often high surgical centres are often high treaters with radical radiotherapy. So what sort of barriers might we see? Well, the argument is always stage 3 disease is a very heterogeneous disease, and I certainly wouldn't disagree with that. However, we see more concrete areas such as lack of access to IMRT. Not every radiotherapy centre is able to routinely offer patients with lung cancer IMRT. Now, that's actually surprised me, and it's one of the areas where hopefully the recommendations have really been in that local action plan have enabled change at that local centre. We do know that some centres will still use chart radiotherapy, but actually in a number of cases we are seeing more attitudinal change. There's concerns about the additional toxicity and about patients' comorbidity in that particular region of the country. Now, that may well be accurate in some places, but actually we're hearing these same arguments for not giving it in a number of different areas around the country. So actually we need to look at how we can benchmark against not only just our own region, such as the Cancer Alliance, but also nationally. And that may include looking at national virtual MDTs. It may involve looking at peer review of radiotherapy volumes. We hear there isn't enough physics time, there isn't enough consultant time. But actually, if we have a robust way of providing that support, then I would hope that we will be able to increase what people feel comfortable to offer patients, and increase the number of our patients accessing the right treatment. So really, just to finish, the challenge ahead is still significant. There's been lots of improvement made, and thanks very much to the data that's been produced by the National Lung Cancer Audit as well as those other organisations. It's imperative that that high quality data is collected, analysed, and particularly owned by the clinical team. But we must be sharing that data and using it to drive improvement, not just at trust level, but alliance level, nationally and internationally. And that evidence that we're having of continuous improvement must be used to secure the ongoing support for data management. But above all, with any benchmarking, we must keep the patient and family experience central to all our endeavours, because that's what we're all here for. And Matt, I think I'm going to finish there.
Fantastic. Thanks, Liv. That was a brilliant talk. I really enjoyed the look back at benchmarking and the history of it, and I took loads of photos of those slides. There was a question that came through, I think during both of our talks, that I wonder if it came out in the work that Gerth's done, saying, is there a national drive to increase PET capacity?
Certainly, it's been a major focus of our GERF visits, and a lot of discussion. I think I have to be conscious that the report is embargoed at the moment. It still hasn't actually been signed off by NHS England. But I think it is fair to say that as part of the GERF process, there's been an ongoing discussion. We've had regular meetings with NHS England, and the PET contract, the KPIs have been a focus of some of those discussions, because we know that particularly the weights in some areas have been very difficult. There's also been variation in terms of access to PET for clinical research, as an example. So I think it would be fair to say we have raised questions for NHS England to discuss with with specialist commissioning regarding the terms of the future national contract, and the bidding process that goes with that. So without saying something I'm not allowed to say at the moment, I think yes, it's been a feature, because PET has been a concern in a number of centres that we have looked at, and we all value what PET adds to our patient journey. And as you say, it changes the whole pathway if you haven't had it before they've had an EBUS.
Yeah. So I'm just going to move on to a few of the other questions. So with the move to ICSs, how will local teams hone into specific locality aspects where improvements are most needed? Averaging data may improve headlines, but less helpful.
I think that's where it's important that any data from within a local hospital has to be owned by that clinical team. So, and one of the repeated themes, I think it's fair to say, with some of our GERF visits is looking at the validation of data and whether that is validated by the whole clinical team. So I think although data is being collected on a broader basis, it's absolutely key that the local clinicians understand their data and know what data is being uploaded, because that is where as a clinician, you are the only person that knows whether you've treated someone with chemoradiotherapy. As a point where it's been exported, we don't always see that there's been cross-validation between the RTGS data set, the SAC data set. So I think, yes, it's been collected, but it's paramount that the local team understands their own data before it goes out of the trust for wider use. And if you understand the data, then you have ownership of it, and then you can utilise that in the wider ICS. Yeah.
And then I think there's two questions that are very linked, I think. So one from Sanjay is asking, if you were a new lung cancer lead, everything we've talked about this morning could be a fairly overwhelming picture of where on earth do you start. So do you have any thoughts about where do you begin on that journey of benchmarking data? And linked to that is that takes time, and it can be quite a rarity to actually have time in your job plan to do benchmarking data, service improvement. Do we have any understanding of how much time people get, lung cancer leads get in their job plans? Is it adequately resourced to give them the time to do it?
So again, without quoting directly from the national report, but more of a reflection on the visits that we've done. We're still doing the visits. We haven't been to every trust yet, but I think it is fair to say that where people have dedicated SPA within their job plans to be lung cancer lead, then there has been more progress made in terms of making continuous quality improvements along that pathway. Now, that's not to say a number of trusts haven't been working very hard, and I think what we have really seen is how much work is being done in people's own time to achieve that. But in a number of the action plans, for example, we have recommended dedicated SPA. A number of clinicians have dedicated PA time, but that's normally DCC. But SPA is absolutely key, because it's only by having time to, for instance, go to network meetings, engage with others, go and talk to the managers. You talked in your own talk about sitting the 3 CDs down in those 3 key areas. Unless you've got the headspace and the time to do that, then you're not going to be able to affect change. I almost used a quote from Einstein about if we keep doing the same things, we're not going to see the same improvement. And I think that's one of the difficulties when people are just trying so hard to keep their head above water. We just keep doing the same thing, just harder and harder. And we're not going to be able to make that step change, which we need to. So yeah, SPA needs definitely ring fencing. In terms of where do you start, I think that's maybe one of those areas where the GIRF visit can be helpful, because we try to look at the whole pathway from the point the request comes in or the patient attends for a chest X-ray. And the action plans that we're giving back to individual trusts are exactly that. They are individualised, and although there are often common themes, they all do differ. So I think for an individual trust, I would say, firstly, use something like the GIRF visit, or go back to that data if you've not had it, and you'll be able to identify some of the things that are obvious. I think most of the things we identify in GIRF visits aren't new to the clinical teams. It's often just highlighting it and allowing reflection within a multidisciplinary environment where you've got not all the clinical members of MDTs, but actually the relevant service managers who sometimes can see the bigger picture for the first time. So going back to those individual action plans, working with your GIRF implementation team to maybe name the top 5 that you're going to focus on to start with. But likewise, not being afraid to approach another trust, see how things are done, because there's so much good practice around the country. We can learn so much from talking to our colleagues.
Okay, fantastic. So I think we will just bring this morning's sessions to a close. We're planning to meet again at 11:15 for the next talk. So we'll look forward to welcoming you back then. Thank you very much. Okay, welcome back, everybody. So we've got the second session of this morning. We're going to move on to service development and demand management. So I'm going to introduce Professor Richard Booton. And I don't often get the chance to introduce him, which I think he's a bit nervous about. When we're putting agendas together for events like this, it's important that there's lots of people representing every part of the country. When we're talking about service delivery, challenges are different in different parts of the country, in different regions. So it's important to get a sense of that. So we're challenged if we've got more than one speaker from an area, but for this one, there is nobody else who can give this talk about service development, because I've never met anybody with the dogged determination to change services for the better, and to never sit still and rest, and to be constantly evolving and improving and bettering services. And many of the things I talked about this morning have been driven by Richard's work and Richard's vision for lung cancer in our area in the last 10 years. So he's absolutely the person to give a talk like this. And he continues to challenge me daily on being better, evolving, making services better. So he better give a good talk now, because that's a good introduction. So over to you, Richard.
That must have stuck in the throat a little. Very kind words, Matt. Thank you very much. Thank you to BTOG for asking me again to come back and speak on something really that I've never spoke on before, service development and demand management. So my first slide, as always, well, actually, that's not my slide, but I have certainly no conflict of interest, but I thought I was, so I'll summarize what we're supposed to be covering. So how to create a case to develop and improve a service, and how we understand pressure points in what we do. And obviously the case for change, overcoming barriers, process mapping, and writing business cases. Now that's a lot in half an hour, although I hope I'm going to cover the subject, at least from an experiential perspective. So my first disclosure really is that I don't have anything that's pertinent to the talk, other than I am not an expert in this area. But I think, as Matt's already alluded to, since I was appointed a consultant in 2008, so 13 years now, we have built a very different lung cancer service here in this tertiary thoracic centre. We now have a clinical directorate that's devoted to the lung cancer pathway, and that includes Matt and myself and various other respiratory physicians dedicated to lung cancer and pleural disease, the thoracic surgeons and the medical oncologists in a single team. And obviously you'll be well aware of all the things we've been doing in Manchester. You'll be fed up of hearing about a lot of it, but in relation to tobacco addiction, accelerating diagnostic pathways, and introducing lung cancer screening, these are all the things that we've done over the 13 years. And in doing that, and I think the reasons Matt talks about what he talks about there is that, you know, we've been very successful at acquiring money and writing successful business cases totaling around about £15 million in the last 5 years. And we have a current case in development for about £60 million worth of investment in a diagnostic and treatment centre for lung cancer to support the screening programme and to support what is essentially the failing 62-day pathway. So I guess this is going to be more of an experiential conversation about what I think have been important points. And whether you're a lead lung cancer clinician, whether you're a specialty lead in a tertiary centre for respiratory medicine and the cancer issues, or you happen to be fortunate enough to be in a more senior recognised management position like a clinical director, these things I think are broadly relevant to everything, obviously different scales, and who you interact with in those different levels is important. So, you know, your managers, your finance people, the teams you consult, the breadth of what you consult is different. But we're all trying to change this graphic, right? This is the bedrock as cancer clinicians that we're faced with every day. And I'm going to tell you a little bit in a minute about our revelation about 5 years into my consultant job, after we've done what I think a lot of people do to try and tweak their pathways to improve this standard. But one of the things we've learned, I think, is that nationally derived targets are just unhelpful. This is certainly out of date as a target. It's 10 years plus old. It's not evidence-based. In fact, it's harmful. And waiting 2 weeks to see somebody if you've got a query of lung cancer is frankly torture. Waiting 31 days to treat somebody for surgery is just embedding delay and harm. And I think more than anything, for Cancer Research UK to put "we will beat cancer sooner" under this graphic, I think is really just one of the biggest misnomers. So look at what's out there. look at what the targets are, make your minds up as a team whether we actually agree with this stuff. Because fundamentally, your chief executive will feel that if you're meeting this target, that you require no more resource. So you have to understand that if you're meeting the 62-day pathway, that's fine, but 1 in 5 people is still harmed by that pathway. They still have stage migration in that pathway. And is it acceptable in a modern day lung cancer service where we know that delay, even to 62 days, is harmful? So you're going to have to make arguments as to why you need more resource if you're compliant with that target. So are these targets relevant? And I don't think they are, and we certainly don't aspire to meet any of them. We are much more stringent. So the reason this all kicked off for me a few years back is, as a cardiothoracic centre, we had lots of people in lots of disciplines with lots of knowledge, whether it's physicians, radiologists, pathologists, surgeons. We have lots of resources. You know, we had bronchoscopy rooms. We've got access to CT biopsy, all the complex physiology. We've got everything you need, bar PET actually. And obviously we have a workforce, whether that's people devoted to lung cancer or a senior clinical fellow workforce. We're just, compared to the average district general hospital perhaps, not surprisingly, we have a lot more going on. But, and here's the cruncher, we were crap, okay? We were no better than anybody else, despite that level of infrastructure. And I think when we saw that, and this was work that came from a Macmillan cancer improvement analysis of the pathway, I think I can safely say that universally, whether it was myself, Matt, the specialist nursing workforce, the Macmillan workforce, the radiologists, we were all just, crikey, this is just rubbish. We've got to be better than this. This can't be allowed to continue. This is like rubber stamping that harming patients is acceptable. The patient experience here is just awful. And so we had a very open and honest exchange of views. The culture has to be one of free speech. And, we have to be careful when we're having that it is a constructive and non-critical environment to individuals, but it is critical of what we're trying to deliver. And so and it starts with a small team. And then as we try and work out what our solutions need to be, then clearly it moves on. But I think looking at that data and saying to yourselves, what is it that we're doing that's wrong? Because we've tried and tried and tried to evolve the pathway, and it's just not worked. And I think we can say that for a lot of hospitals across the country, because the audit would still support the fact that there's still a lot of unacceptable practice, despite 10, 12 years of the audit. So what did we do about it? Well, I think, as I've said, there was already a very clear and singular belief amongst all disciplines that patients deserved better and that evolution had really just failed. Okay. So I think we were honest. We put the driving force here was patient experience. So why do you want to change pathways? That's the question. Why are we trying to do service development? What is it? And back in the day, 2015, there was not really much evidence around about patient outcome and delay. So much of our motivation was just about offering a patient a much better patient experience. The desire to change was common, and that's a great starting point, because if some members of the team don't want to change anything, that's really difficult. But if we're all on the same page, then we can start presenting a team view, not only in a medical directorate, but possibly even a radiology directorate, possibly even in a pathology directorate, and the management structure matters. And who do you engage with from a clinical leadership perspective? For me as a lead lung cancer clinician, it was probably my clinical director for respiratory medicine. But now as a clinical director of a service, it's probably my head of division, possibly my medical director. And equally, the same is true of management leadership. Is it a directorate manager, a divisional manager, or the director of operations? And some of that is not necessarily about the project, but some of it's about the size of the ask. So if you're asking for £15 million, well, I can guarantee you're going to be having conversations with the chief executive and the director of finance and the director of ops, rather than at a directorate or divisional level. So getting to know the right people is really important. In truth, although we felt revolution was necessary, none of us had the skill set to deliver system-wide change. We're clinicians. What do we know about doing that? Certainly, I'm old school. I think there's a lot more focus on quality improvement in training nowadays, but we really didn't have the skill set to even know where to start to approach this. So you go to the professionals in your organization, and there are lots of teams now about change management or project management. And so we enlisted a bit of that support. But I think I'm belaboring the point, but I think doing nothing or tweaking was just simply felt to be unacceptable. Root and branch review, it's a phrase that's used a lot perhaps, but it felt like that was time because tweaking on its own was not working. Sorry. So here's a very blurry picture, I'm afraid, but I think it sums up the high-tech approach that we used for this service review. We have the head of the project management office next to me. You'll see my trademark sweater and sartorial elegance. And my directorate manager at the time in the stripy top. And this was probably 20, 25 people sat behind us trying to work out what the lung cancer pathway was from start to finish. Okay, so take the GP referral, what happens to it, where does it go, who's involved, every single step of that pathway, all the way through to the MDT and to the treating people. And you have to tailor that process to what you have in your hospital. Obviously, there's no point talking about surgical pathway if you don't have surgeons in your hospital, and there's no point having oncologists involved if they're not in your control. So this was an exercise that was very team-based, from the bookings clerk who takes the 2-week wait referral from GP, to the chest clinic clerk, to our secretaries, to just everybody involved in mapping that pathway out. And once you've mapped it out, and in preparing this talk, I managed to find this, which I'd completely forgotten about. There are 3 slides coming next where we talked about issues, challenges, and solutions. So having done that sort of brainstorm, and we put all these post-it notes up on the wall, I'm not sure if you can see all the detail under there, but just trying to say what we thought the issues were in the pathway. And these aren't going to be a surprise to anybody. Timely access to diagnostics, lack of staff to deliver the pathway, lack of investment from the hospital, the appropriate bookings into clinic, the complex pathways we have, trying to get the CT reported before clinic. All, you can see that when we scored as individuals, what do we think the most relevant, maybe take the top 5 you think are the most important, and then you've got 8 people said, timely access was the problem. That gives you a very clear plan of attack to trying to change the pathway. And it is multi-stakeholder owned. Okay, it's not just a bunch of clinicians sitting at the top of the tree saying, we're going to do this to you. This is right up from the grassroots as a very big team. And actually, I think Matt will agree when we did this, meeting the bookings clerk that we never ever met, never even knew the name of, was a wholesome experience. What do we need to do to improve things? Again, that same team, one-stop shop, doing things that support the pathway. I can't remember. I think that was roles that support the pathway. So this is where our concept of navigators came from, and that's become a thing that's rolled out a lot now. The infrastructure within, new daily patient clinics. Nobody should wait a week to see somebody with a question of whether this is lung cancer or not. But then there are challenges there, aren't there? And how do you then support a new daily clinic? But if you understand the challenges and what you want to get to, you're describing the problem. Now you're describing the ask of the system. Is a very useful thing, and I think that whole team approach is very, very important. And then there were just some comments about things which, again, I think will ring true with a lot. That morale, there's lots. Anything that has a target, and anybody in A&E today will tell you that they're being battered by lack of performance. And if you've got that in your pathway, that's not sustainable. It's not fair on those individuals to be battered, because frankly, as the audit will tell you, the organizational audit will tell you, and GIRFT, I think the big key message here is that We do not have enough people, infrastructure, estate to be able to do this better. But hey, we're now 8 years down the line from this, and at least the audit is recognizing that now. You know, your managers start to say, well, we've got to do cost improvement programs. So I know you've lost your navigator or your admin person in the chest clinic, but we're not going to replace that for 6 months because, you know, we need to save a bit of money. And that has a fundamental knock-on to the efficiency of the pathway. So lots of these things. Hospitals are full of red tape, full of unnecessary processes and procedures that just get in the way of moving people along. And if you've heard Matt or I talk about the RAPID program, you'll know that we probably cut out 20 steps from a 2-week wait referral coming from a GP to arriving in the radiology department for a scan, just by doing that pathway review. And it went straight from bookings team to the radiology department, and the scan happened the next day. Physicians don't need to look at this stuff. We don't need to request it. You just have to work as a team to cut out the unnecessary rubbish. So in the end, the project management team drew this fairly complex diagram, perhaps, but it was an attempt to reflect what we felt we were aiming for. So again, pictures are great to try and convey the solution you want to try and get to. But of course, again, you can't do all of this, and we are still 8 years down the line. We are still evolving this RAPID program. Yes, we've been successful at the front end with you know, it's almost direct access to CT and hot reporting and seeing people the day after and telling them they don't have cancer, etc. But we've still got a massive elephant in the room when it comes to access to diagnostics and hot reporting, and shortening that pathway down to 14 days, aka the optimal pathway. And in terms of how we get the surgical decisions made when people need to go off and see anaesthetists and oncologists and have their, you know, physiology reevaluated, that's still a work in progress. So these things are not something you can do for 6 months and then stop. And I think it's been said to me this morning by my director of finance that what's clear, one of the things the exec like is the passion and the determination to drive this along. It's clear to see, they tell me, in my, I tend to view it as being a complete pain in the butt and irritating people. But they see passion, which I think is obviously much nicer, much more positive. But this is an evolving piece. You've got to remain determined. You've got to retain your goals and your vision. And of course, they do evolve over those 8 years as well. But we still have a very clear vision and strategy for what we do. I suppose as a team, and that team has evolved from, as I say, local chest clinic type teams to divisional and directorate structures now. But as a team, I think we've tried to create that culture of change that, you know, we are on a journey. We are driven by patient experience and patient outcome, and that is very hard to argue with. This is not about making Richard Booten a professor. It's not about making, you know, getting me a Gold Excellence Award. If that happens, it's nice, and it's recognition, I hope, for work that has transformed something of patient value. And when we talk about things, we do have fairly big opinions, you know, so delivering ideas that change the world. You know, we're not trying to just, you know, make Wythenshawe a little better. You know, we're gonna, in fact, Matt is better than this than I am. Matt is very good at publicising this and pushing this out of the institution. And that has genuinely had an impact in our Cancer Alliance. The courage to disrupt what we do, to challenge those NHS England targets, to tell the hospital that they're not fit for purpose. Yeah, because it's about patients, and it's about making sure that we offer the best that we can possibly offer. And that's true regardless of tertiary or secondary care. So the impact on patients is central. That's our focus. And I think that is very key, because when you're sitting in a management meeting and somebody's getting a bit nervous about the spend, it's very difficult to say we don't care about patients. Doing things for patient impact when it's the leading cause of death and premature death in our network, things have to change, and this ends up being a priority for the institution to invest in. Commitment, teamwork, pride in what we do. I've been blown away, I think, when we've done all these grassroots events to see just how enthusiastic people you wouldn't think would be enthusiastic about their work in terms of changing things for patients. I remember having conversations with our divisional finance team, and their whole motivation for coming to work was to improve patients' outcomes, saying in 10 years, I was a part of that. You tend to think of, perhaps the tradition is to try and think of them as bean counters who are trying to stop you from doing stuff. But that's singularly not been my view of certainly our finance team. So again, getting out, meeting people, understanding the blocks from their perspective, how we work to a common goal is, and trying to retain that focus on the solution is really, really powerful. And I think cross-discipline is always great. I cannot go into a radiology department, even with a professorial title, even with a clinical director's title, and say, you bunch of radiologists need to change what you do. But if I've got a radiology champion who's bought into the culture of what we're trying to do, then that person certainly can, but change the messaging that's fit for their discipline. And that's why we have been successful. We had, as you know, Anna Sharman, and now we've got Alberto Alonso, really trying to drive things along for achieving the aims of what we need to do. So in a way, we broke this down into manageable bite-sized things. What's the easy win? What's the quick win? And we very much felt that phase one of this, which was GP referral to first outpatient clinic, was the win. And that's what we focused on. And in a way, that's what we talked about when we talked about the RAPID program. I'm not going to dwell on this because this is not about the RAPID program. This is about the general principles of service development. So I think, again, if it's a big piece of work, you've got to try and break it down into manageable pieces, because nobody wants to do a piece of work that becomes undeliverable, because we all lose enthusiasm. We all get a bit despondent if it doesn't work. So bite-sized pieces, retain the focus, get one thing to be successful, build on that success by moving into the natural next element. And I think that's very much where we're at now with the diagnostic piece and the treatment piece. And I'll touch on that a little later as well. I think it is important when you're a novice to this to just, and in a position of leadership, you've got to go and do a little bit of reading, try and, when you're trying to convince people, how are you trying to convince them? So this is not just because I said so. What we're trying to do is move from a system that is not safe, is not effective, is certainly not patient-centered. One of my senior colleagues coined a phrase which was, what patients basically endure is waiting for capacity. But what we actually need to create is capacity that's waiting for patients. Now, that is a totally foreign concept to the NHS. The NHS thrives on a waiting list, 100% slot utilization. And if that's the case, then I cannot get something. If I want to do a bronchoscopy today, my slots are all filled. If I want to do something tomorrow, there's a waiting list in CT for the next 3 weeks. So we've got to change what we do in cancer that allows us to do things today and tomorrow, not next week or the week after. And that is a fundamental challenge to the management principles that the director of ops wants to follow. 100% slot utilization to them is efficiency. To me, it's inefficiency in delivering a cancer pathway. It needs to be timely, it needs to be efficient, and we need no variation based on patient characteristics, which, so these are good principles. You can reference a document. The Health Foundation is clearly an excellent institution for quality improvement work, and we had some grant money as part of a RAPID program from the Health Foundation, and that was very useful too. And I think I'm touching on that in a second. Again, lots of documents about changing and delivering services in NHS back in the day. And these are all good phrases. If you've got a document that's out there that's current and modern today, when you're talking to managers, referencing that it is consistent with the direction of travel of the NHS. So I suppose relevant to the NHS long-term plan. relevant to Sir Mike Richards' review on screening, relevant, you can get the feel of, so they get the security that knowing investing in something is going to achieve some of the current things the health service is expecting from us. I won't dwell on this too much, other than to pull out, I think, making conclusions that help with your argument. So at the moment, patients wait for hospitals to get their act together, and we need to change that. We need to be ready to do things today and tomorrow. Delay, we have to have a systematic approach to it, particularly in lung cancer management. And we have to have a very clear direction of what we want to do. It's always nice to have snappy things, so revolution, not evolution. I think that people can get behind the messaging, the size of the ask there. This is not a small piece, this is a big piece of work. And as I say, professional help is good. External grants are very useful, and this was only about £75,000 that we had from the Health Foundation, but I think what it brought to the initial piece of work we started was some very professional quality improvement skill set. You get allocated a guy with those skills to meet with you weekly. You have to give progress reports, you have to identify blockers, and then they will pick up with the organization what you're doing about those blockers. We had a medical director who was our executive lead. He was responsible for making sure we delivered on this grant. Data collection is pivotal. Again, I'm going to talk about that in a minute, but don't miss the opportunity to measure what any pilot change does, because it's really important for implementation and sustainability. The grant allowed a framework for evaluation. It does provide some funding, but mainly the value is in the skill set they bring along. But it does also, because you have to write a grant summary, and you've got timelines, it gives everybody a very clear focus. And as I say, having somebody like the medical director responsible for meeting those timelines certainly gets the visibility in the executive team and unlocks any challenges. There's lots of stuff in here about overcoming barriers, and I've talked about clinical champions in each team or area, educating people about what you're trying to do. It's patient driven. Yes, it's more difficult for you, but this is why we're here in the health service. We did a lot of stuff on a wing and a prayer. Probably wouldn't recommend doing it without finance and some support, but sometimes you just have to get on and make the change, regardless of your job plan, and I think if the team can agree that, that's fine. But we then have to think about the sustainability angle once you've got some evidence. We are very much about codependency as a team, and there's no point in arguing for hot reporting from radiology if it's going to take a physician team 3 days to look at that report. Don't ask for what you won't do yourself. In fact, you've got to lead by example, haven't you? Trust structure can sometimes be a barrier. I think I've got a slide that talks to that, so I'll skip that for now. But I am an absolute fanatic about command and control. I'll happily be responsible and accountable, but I have to be exactly that. I'll lead a service, I will be responsible for it, but I need to have command and control. I'm not accepting anything if I don't have that, because people need to respond. We have standard operating procedures, we have standards. We will implement them, and we will measure and challenge and respond if it's not. But there's no point if you don't have command and control. The narrative when you're trying to do this stuff is important. We can talk about wait times, we can talk about what is a major risk in your organization and action plans. But when we're looking at screening, for example, biggest cause of premature death, bigger driver of health inequality in a population. These are the sorts of narratives you will put into any sort of business case or ask of money to try and get that context right. What would I say? So I think in the interest of time, I'll probably just skip the rest of that. But I think pump priming definitely has a role. But what you shouldn't forget with pump priming and getting a bit of resource to change things is that you have to then have a plan for how you're going to keep that person in post. And that you can overlook, and that can then destabilize a very successful project. I don't know why that one's not shown. There it is. So you've got to use everything at your disposal. You can't wait for the bigger and best thing tomorrow. So, simple, cheap, Outlook calendar helps us to run the service better, okay? But equally, standards around what you're trying to do means that everybody in your team knows exactly what's required. And now that we have these standards, and you'll be familiar with these diagnostic standards of care, this is easy for the nursing staff to challenge the medical staff. Why are we not asking for a CT brain in stage 2 and 3 disease? Why have we not done a PET scan here? Why are we not doing a CT biopsy? Why have we forgotten to ask for the echocardiogram? These bundles of tests and the check and challenge from all members of the team by applying that standard really does help to move the pathway forward. And then, of course, you have to measure what you do. And this is the beauty of data and measuring what you do. The simple things we did for very little money transformed our practice. That's on the left. And then we have patient feedback to say, this was brilliant. Because a lot of the rhetoric at the time was, this will be too fast for patients, they won't like it. So I've learned that a lot of expert wisdom, for which there is no evidence, is often fundamentally flawed. Get your patient data, because it is absolute. And we're seeing this as well now with patients don't like to travel. Fundamentally disagree with it. Okay, the patients will travel, but they have to. It's for the right reason, and it gets in the way of planning effective care. This is probably more relevant to tertiary centres and divisionals. How we set up, how a hospital manages its divisions in a hospital. We've here traditionally for a long time had a division of medicine, division of surgery, and support services separately, and they all have divisional medical directors, managers, finance managers, and then directorate clinicians, managers, and nursing staff. And to make a change in the lung cancer pathway, you have to influence all of those people, and of course they all have differing agendas every day of the week, every month of the year. So that's really difficult to negotiate. And we've been very lucky, I think, in that with the work we've been doing, the executive have realized that actually that doesn't work. And we're having a single directorate for lung cancer and thoracic surgery, where we're bringing together the key disciplines, and we've got a single point of command and control. And this is really helpful for driving our change forward. So what do you do after you've done that first bit? Well, you've got to keep going. You've got to build on that pilot data. You've got to look for broader implementation, and that's where the business case comes in. But that pilot data does allow you to develop a much more robust business case. And that's important because everybody will talk about risk and what's the risk of investing that amount of money, and is it going to deliver what you say it's going to deliver? Well, you can say, well, if I do it in the way that we did it, you can see that we're going to transform, MDT. Time, and we're going to improve patient satisfaction. So in the data side, and I want to labor this a little bit because I think whilst spreadsheets and data are not everybody's cup of tea, in the rapid pilot, we had the foresight, I think, to categorize our referrals by whether they came from GP, whether they came from hospital, or whether they came from our screening program. And we also had the foresight, because we were developing these bundles of care standards, to record what that baseline CT scan looked like. And that data is just not out there. So if you were trying to plan how many diagnostics do I know on the basis of how many stage 1 lung cancers did I diagnose last year, that is not the right denominator, because there are lots of people who look like they've got stage 1 disease on a baseline CT that end up having stage 2, 3, or 4 disease when you do your evaluations. So the bundles of care and the baselines are a really important thing from a business planning perspective. And those bundles were, by the referral route, by screening or 2-week wait, were again very helpful when it comes to planning out changes to the diagnostic pathway. And similarly in screening, what's the proportion of people that are 55 to 74? What's the proportion of people we know to be ever smokers? What's the conversion rate to CT using PLCO? And now, of course, PLCO and LLP. These are the very big numbers you need to understand the impact of establishing screening in any cancer alliance. So data, and understanding it is absolutely massive to credible business cases. Now, in our screening business case, this is what it ends up looking like. This is the cancer, this is the screening pathway from invitation to lung health check to CT, and the conversion rate to cancers, 2-week wait referrals, to cancers diagnosed, to what stage of cancer and what therapy somebody had. But now we can do that for one CCG. I can also do it now over 2 years. I can now run that over 16 years, and I can see over a period of time what that impact has to this cancer centre by introducing that, not only over a longer period of time for one CCG, but I can actually model this for all 10 CCGs and see how that feeds into the thoracic surgical and the diagnostic environment. So the business cases clearly are required for major investments. I've said modelling is important. We have to have an understanding of your activity, what income's associated with that, and how the working model is going to change the workforce requirement. The estate may have to change as well. Of course, that's very expensive. And now we're approaching, the implementation of screening. The infrastructure required for that is going to be very different to what we do currently in standard lung cancer management. And the business case has to address a whole raft of risks, financial, workforce, training, education, a whole raft of things in order that you can be successful. But if you write the right case, you can get a sustainable and safe, quality assured service. And because of that data, and because of the way I say you can write that, I can now produce a graphic like this, which basically said that over 15 years, the rates of stage 1 and 2 disease will go up, the rates of 3 and 4 disease will go down, and the number of life years saved per year is the grey bar underneath. Okay, so you can do all of that work, and that is evidence of the impact of introducing this at scale across a cancer alliance. And this is a very hard debate to counteract. Nobody, in fact, everybody I show this to now, we're quite advanced with the Cancer Alliance and the partnership in Greater Manchester. As far as the organisation is concerned, this is a no-brainer. It addresses health inequality. It is going to change outcomes for the leading cause of premature death in Greater Manchester. So that's where we're getting to with this level of data. So I guess my personal reflections are that, yeah, dogged determination is important. Patience, it's a slow process. But, if this is my legacy in 10 years' time, I guess I'll retire a very happy man. We do things that are for patients first and foremost. Hospitals second, and sometimes it's hard for hospitals to follow that patient first agenda, and it's often very hard for individuals to follow that because it means we have to do more things that we haven't previously done. Get rid of unjustifiable delay. Do things today and tomorrow, not next week and the week after. And as I've said, develop the capacity to do that today. Tenacity, passion, drive, whatever you want to call it, they're key features, I think. And if there's many people, I've never, this is not me doing this alone. Matt is absolutely key. The radiologist, Anna Sharma, has been absolutely key. My nursing team, absolutely key. The management team, absolutely key. They've all got that tenacity and passion and drive. And I think it makes a very efficient team and leadership team. Engage widely, get to know everybody, pull in favors, promise things to get what you want, and definitely use that champion's phrase. And educate people as to why we want to make the change. If there's a naysayer, there's always late adopters, but ultimately they just don't understand the bigger picture usually. I've talked about data. Innovation, I think it's good, keeps me interested. Lots of new ways of working. We have team job plans now. It's much easier to do a day by day, cover the various things we have to do every day. And we work very much on who's around today, who can do what. Just get the job done. Standards are key, SOPs for implementation. Everybody signs a contract saying they'll follow SOPs of the organisation. Now, actually, you're contractually obliged once you've approved those SOPs to follow them, and make sure we have KPIs that we're measuring what we've done, that we're meeting them. If we're not, we need an action plan. We need a risk register. We need to highlight stuff so that the organisation responds in the most appropriate way. So that's I guess my personal reflection. It's I hope I've addressed the ask, and I'll stop there and ask Matt to criticise me constructively.
Thanks very much, Richard. Brilliant look back on over a decades of worth of work, and there's some absolute gold dust in there.
Yeah.
So there's a good few questions coming in. So this is a good question. If you were a brand new lung cancer lead, what are the first 3 things you should do to address service improvement?
Well, I think if you're brand new to that position, I think you've got to bed in. Nobody likes a smart aleck that comes along and wants to change everything and hasn't been around for a while. So I think you've got to bed in. You've got to work with the team. You've got to understand who the key players are at the moment and the challenges in that system. And I think in many ways that's what we did, wasn't it? I was fairly new as the lead clinician 5 years into consultant job, and we had that view, but it wasn't about that lead clinician just saying to everybody, right, guys, this is rubbish now, we need to change. This was about, what do we think of that data? Where are we going from here? We can't keep doing this and expecting the same, different results. So I think it's build some relationships, it's understand your data, it's pull together the right team that's going to be able to reflect the thought process to the whatever level of management you need to go through, whether it's, as I said before, the team within a directorate or the division or the hospital board. I think that's the basic starting point. And then pull, as I say, I think one of the key things for me when you've not done the management stuff before, and I'm certainly no expert in management either, but pulling together as much evidence as you can at the time for what the national agenda is and what the gap analysis is, what documents are out there for change that supports the process, and that whole stuff about how you change a service, and again, where you're deficient in safety, quality, effectiveness, because it's very hard. If you write that down in a paper, 2 pages, and give it to your director of ops or your managing your medical director, very hard for them to turn around and say, you're talking rubbish, guys. You've got to make it difficult for them. They'll challenge you back, clearly, but you have to know your stuff, and you have to represent it in a way that managers understand. I guess that's another key point, isn't it?
And I think it speaks to, there was a question during Liz's talk that we didn't have time to get to, was about how do you bring in board level NHS leads to take note of benchmarking data and invest in services? And I guess what you've just said speaks to that in volumes. But anything you want to add particular about how do you get the attention of a chief executive or of a director of operations that can empower the vision you're setting out?
Well, I think the way it's happened here has been that we have done some really good work within the directorate and division at that level. And of course, that doesn't usually come across the board's viewpoint. But when you've done the RAPID program, when you've done the MSIP screening pilot, and that type of work is then feeding into how we then support systematic change in what we do, you've then got evidence. You can scale it up and say that if we did it in a different way, this is what it looks like. It's obviously helped. Obviously, we submitted a lot of this work to things like the HSJ awards and the BMA awards, to patient experience awards, and we've won a lot of those. So again, people might regard that as being a bit of a jolly, but actually it's a massive peer review process. And it's other people saying that this is really incredible work. And I think getting a HSJ award is no big, most chief executives understand that. And I think that's how it happens. You've got good data, you've got transformative data, you're getting peer review, GIRFT has been good for us this year, hasn't it? In terms of referencing 10 or whatever many things that we do, that's peer review, and most chief executives don't generally listen to internal, we're great, we're brilliant, but they do listen to external, oh, he's great, he's brilliant, or that team is brilliant, and it gives them the reassurance that investing in them is the right thing to do. So, yeah.
So I think there's another interesting question just about the impact of COVID, and it's been awful for lung cancer outcomes. Set us back 10 years. But if there was anything positive about it, that it's shown many people that the bureaucratic hurdles can just be overcome and broken down at a time like that. But so the question was, how can some of the bureaucratic hurdles that came down for COVID be captured within pathways and evidenced as unnecessary to managers to facilitate change?
I think there are two things to that, isn't there? I think it feels to me like a lot of what happened during COVID was just shutting down some services, not really saying this is not the right thing to do. I think 70% of our service carried on, and it carried on face to face, because we took a view, didn't we, that patients need to come and see us. If we need to do a bronch, then we'll put our PPE on and get it done. I don't care if they're negative or positive, we just get it done. Same for thoracic surgery. We kept a service going because it's the right thing to do for patients. I think data demonstrating that by losing this didn't detract from the quality, but then if you're saying we can get rid of that bit, but we can reinvest it in a different way. We've talked a lot over the years about, we have a cancer services team that document how crap the pathway is. That's their entire job, to watch how crap the pathway is and document it. Why aren't we using these people to help facilitate a better pathway? There's no point in documenting a crap pathway. You want to use those, but these are large numbers of people in an organization who actually, if we said, right, you need to help in the administration of speeding up the process of getting appointments and people, that would be a far better use of that team. And then the targets go away anyway. You meet them by default. So I'm not sure if I've answered your question actually, but I don't know, because I don't think we necessarily had that challenge. We didn't let anybody. Maybe that's the answer. We didn't let anybody take our service down or change it. We said, no way, Jose. We are carrying on. That's the end of it.
Okay. So I think we're just a couple of minutes over time, so it's probably the right place to call that to a close and let everyone get off for lunch. And we are meeting back at 12:45. And my co-chair, Sanjay, will take you through the afternoon session. So thank you very much for joining us this morning, and we'll see you back after lunch.
Thanks, everybody.
Welcome everybody to this afternoon session of the BTOG Masterclass, Leading Your Lung Cancer Pathway. And we had a really interesting session today. You can refer to that on catch up if you missed it this morning. But tonight, this afternoon session is really fabulous too. And we're going to start off with a topic area that I think is really important, and that's leadership. This whole session today is about leading your lung cancer pathway. And our first speaker is somebody who is well accustomed to that. He is Dr. Nicholas Farnas, who is the medical director at the Royal Marsden and is a specialist in clinical oncology and has played a leading role in the UK with respect to SBRT services. So, Nicholas, over to you.
Thanks, Sanjay, and thanks to the faculty for asking me to do this. So, let's see if this internet clicker works. So the official conflict of interest declaration, and there's my disclosures on this, and I think it's clear we're always continuing to learn, and I definitely am still trying to figure this all out myself. So when I was asked to give this talk, I realized it's probably it is the first time I've ever been asked to talk about leadership, and I couldn't do what I normally do when I'm giving a talk about prostate cancer or about radiotherapy and dip into a very large bank of slides and rehash many talks I've given before. So I thought, well, where do I start? So I went to Uncle Google, and I thought there must be lots of good information about leadership, and tutorials that I could read and papers that I could look at just to give you an idea of how I would address a talk on leadership. And there are lots of different things on the internet about different styles of leadership, things like authoritative, democratic, coercive, and there are multiple other styles of leadership that are described. And when I read these, I found, well, I couldn't sort of really put myself or really fit leadership into any one of these boxes. And I felt, well, actually, I don't think I fit into any of these particular styles. There's bits that I can get from all the different styles, but I didn't feel that I could really describe leadership in any one particular box. So I resorted to talking about my own experience, which I hope will be beneficial to you. So I'm going to divide it into two parts. One is leadership in a management sense, particularly in reference to my role as medical director, and then a different context into research leadership. So just a little bit about me, so it puts it in context of who I am. So you can probably tell from my accent, I didn't grow up in the UK, I grew up in South Africa. I moved to the UK in 1997. I intended to stay for 1 year, do some locums and some travel, and I have never left. Married, 4 children, growing up English, so yeah, all quite not what I really expected. I trained as an SHO in Cheltenham, and then I did my specialist registrar training at Guy's and St Thomas's Hospital in the Royal Marsden, and got my fellowship on clinical oncology in 2004. I did a research fellowship at the Marsden in between 2004 and 2006, and then was appointed as medical director, consultant in 2008, and then became medical director in 2016. And I actually hadn't done any previous leadership roles in the hospital prior to that, so it was quite a big step. I've been research active my entire career, and it's part of my career, my job that I really love. And I was really proud that this year I was awarded an academic personal chair at the ICR and became a professor in June this year. So let's start with the management side. So a few things that I've learned along the way. The first one is be brave. And why do I say this? Because sometimes the decisions that you have to make are difficult, and it can be quite scary to make these decisions. And one of the things that I found most difficult when I started was people brought decisions to me because they were difficult. No one else had yet been able to make them. So in whatever leadership position you are in, you will find that you are asked to make the final decisions. And the thing I found really difficult to get used to is when I made a decision, that's what happened. That's what the action then followed on. There was often no further discussion. That's what the medical director said, and that's what happens. And that actually took quite a lot of getting used to, and it was quite scary that you had to take responsibility for those actions. But you do have to be decisive, and that is one of the key things of leadership. Indecision means that you do not make progress, and you cannot instrument change. So you do have to be decisive, and you have to accept the fact that sometimes you'll make mistakes, and everyone will. So not all the decisions you make will be right, but you're in the position because you are experienced and you have a good judgment and knowledge of the area. So you do have to be decisive. The next one is being fair, and this is probably one of the most important things, I think, in any leadership role. When you're dealing with other colleagues or people, you have to treat people fairly, and you will have to deal with people who you like, people who you like less, but you have to treat them all exactly the same way. And I think people can accept difficult decisions. They can accept when they've made mistakes and you've had to act on it, as long as you do it in a fair and transparent manner. And leadership, unfortunately, is not a popularity contest. So you will make decisions. You will, if you're instituting change, there's always going to be people who don't like what you've done, and there'll always be people who think wrong and people who will criticize what you've done. So you have to be able to accept that it is not a popularity contest, and therefore it can be lonely. And I think things that you need to do to address that is you need to have senior colleagues around you who you trust. You aren't actually alone. Most of these decisions are not going to be yours alone. You'll be making them with other team members, even if you have to make the final one, but you are not alone. And it's also useful to have some phone of friends, particularly outside your organization, people who you can lean on for advice, colleagues, senior colleagues from other organizations, or even other areas of life that you feel that you can just use as a sounding board. And the other thing is, if you believe it's right, it probably is. You've been in doing whatever you do for a long time. You will have good judgment, good knowledge. And if you think it's right, then trust yourself, because it probably is, and you need to stick with it. So what about being faced with difficult problems? There are very few serious decisions that have to be made very quickly. It's not like a recess situation where you obviously have to make instantaneous decisions, but most decisions you can take time, and you need to slow down, because it's dangerous to shoot from the hip and to make decisions too quickly. You need to get all the information about whatever the problem is that you're facing, and you need to triangulate it. I can say 100% certainty for every serious incident I've dealt with since I've been in this role, from what the first person told me to actually what happened, are two often entirely different stories. So you need to triangulate. Do not take what the first person tells you at face value, because almost certainly there'll be significantly more to the story than it was initially evident. And if you make a decision too hastily, you may go down a path that you don't want to go down. So take your time, get all the information before you decide what action is needed. And this is really particularly about senior leadership. If you do end up in a senior leadership role, the roles come with power and privilege, and they are exciting, and they're really great jobs. But with that becomes huge responsibility and pressure. So you've got to, if you want to take on senior leadership roles, you've got to be able to deal with that. And how do you? Well, I think getting a coach. So before I had this job, I didn't even really know anything about coaching. But early on, I got a coach, completely external to the organization. It was really helpful, because coaching tells you a lot about who you are and how you respond to situations. And I learned a lot about myself and my own leadership style by having a coach. And I think it was really very beneficial, and I would strongly recommend it if you do get into a senior leadership position. The other thing is build a strong team around you. I like to think that my team around are brighter and more talented than I am, and my job is just to keep them going in the right direction. And I think surrounding yourself with really good people is key, and it makes the job a lot more fun and stimulating, and it means that you are not working in isolation. So build a team is really key. And the other thing is, you have to accept that you take responsibility for the problems, you take responsibility for the things that go wrong. But when things go well, it's important to share that and to give credit to the team, because it won't be you alone, and rather give the credit to your team and take the trouble on your own shoulders. And leadership is not a one-size-fits-all, and there's no point in trying to lead like other people do. You can learn from others, but you've definitely got to find your own style. And for those of you who don't recognize the man in the photograph, this is Siya Kolisi, who's the current captain of the South African rugby team, who led, probably slightly unexpectedly, the South African team to win the World Cup. And he's a truly inspirational leader, and I would love to say I could lead like Siya Kolisi, but I have none of his talent. But there's still things I could learn from him, and that is how hard he works on the field. He would never ask any of his team to do things he wouldn't do, and also just the pure passion he has for the role. So although I could never do what he does, it doesn't mean I can't learn some of the things from the way he leads. Sorry, I'm going to use a clicker which just keeps going off. Phil, my slide's not advancing. Can you give me the next slide? So if you are in a leadership role and you've been asked to do it, there's a reason why you've been asked to do it. It's because people believe that you can. And so you have to believe in yourself. Sometimes imposter syndrome, which is, feeling like, why am I here? Why am I doing this job? Is very common. I've certainly suffered from it myself. But there is a reason why you're in the role, because people believe that you can do the job. But sometimes the only person who doesn't believe that is you. So really trust the fact that you've got there for a reason. Believe in yourself. So let's talk a little bit about research. So change tack a bit. So for me, some of the key things to leading successful research are the following. The first one is something you may not always be able to control, but it's research. It's working in a research active institution. This doesn't have to be an ivory tower or a big academic hospital, but your center needs to support research, because it's definitely not something you can do in isolation. Get mentors who will support you, but also let you fly solo. This is key. Again, you may not always be able to control, but look around. It doesn't have to be someone who you trained with. There are senior researchers out there who love to help and support colleagues build their careers. And this was my mentor, Professor David Dernley, who was my academic supervisor when I did my MD, and then gave me huge support as I was building my own research portfolio through the early part of my career. And although he's now retired, he was definitely one of the first people I told when I was recently awarded a chair. Good ideas. Well, this seems so obvious, but you need to solve problems that need solving. Quite often I see research fail because it's a so what. So you get to the end of the project and it hasn't actually moved anything forward, and it's because the question really wasn't that important to start off with. So really focus at the start on what are the problems we need to solve. Keep trial design simple. Again, I think some of the studies that fail are because people have overcomplicated and tried to answer too many questions simultaneously. So keep the design simple. Build networks and engage colleagues early. So although research is competitive, it's also much more fun to collaborate. And I find, these days people are much better at collaborating. And that's not just within your own institution, but widely, nationally and internationally. And I think the pandemic as well has made communicating in the virtual world the norm for us, a bit like we're doing today. And it has made collaborating more widely, more easily. So Twitter is, I'm not really particularly big on social media, but I do use Twitter for research, and it's a great way of keeping up to date with what's happening and also communicating with research colleagues. So from your community, the legendary Sanjay Popper up the top there is very active on Twitter, and people like Fiona MacDonald and Shankar Siva also active in the lung community on Twitter. And sometimes there's comments like about how good we are in the UK. So this was from Shankar, just pointing out that the UK has a knack of completing studies that no one else can do. And I think that's true. We are good at research in the UK. We are good at running studies, and it's a great place to do research. And the final thing is work hard. Research isn't easy, but you do have to work very hard at it. I think of it a bit like this. So success in research is big impressive iceberg on the top, but actually what's happening underneath is even bigger. It's hard work, persistence, the late nights, rejections, sacrifice, discipline, criticism, doubts, failure, risks. All of these things are happening under the surface of the successful studies that are, or successful research outcomes on the top. For me though, research is fun. it's definitely the best part of my job. It's the part I enjoy most. It's definitely the most satisfying. So if you're interested in research, I'd strongly encourage you to continue with it. So enjoy leadership, try and inspire others. This is truly, for me, the most inspirational leader of our time. I had the great privilege to meet him on one occasion, and it's truly the I've been utterly starstruck. Stop there. Happy to take questions.
That's fabulous. Thank you very much, Nicholas. And I've got a few questions whilst hopefully other people send them in. So my first question is time management. So you were talking there about, your kind of clinical management role and medical leadership, and also your research. So a lot of people, I would imagine, as they lead their lung cancer pathways, will also have, a full job plan and think, how can I fit this all in? How do you fit it all in?
Yeah, it's a good question. So, I mean, I still work clinically, but I had to downsize my clinical practice when I became medical director. So I had to drop a certain number of clinical sessions. For me, research, although is really important, I've probably always had to fit it in more of a kind of as a hobby in a way. So a lot of the research I do is probably in my own time. The medical director role, although it's meant to be a 50-50 job in terms of 50 clinical, 50 medical director, the job kind of evades all part in my time. So yeah, it is busy, and at times it can feel a bit overwhelming in terms of time. But I think that, the easy thing to drop would be the research, because I don't have to do it as such. But as I said, I do really enjoy it, and I don't find it a stress or as much of a burden. I enjoy the research. So I think that's it. If you want this kind of role, you've got to accept that your time is going to be very full. But if you enjoy it, then it's easier to do it.
Okay, all right. And what you talked about coaching. Not everybody will necessarily have the resource or access, although what I can tell people is that there's something called the Faculty of Medical Leadership and Management. And if you go to their website, they have a number of coaches that you can link up with for coaching. and I think it's a valuable thing. Now, it tends to be something that, senior people, senior leaders access, I think, more commonly. And you mentioned mentoring with respect to research. Do you think we need to do more in terms of mentoring or coaching within the lung cancer community? I know you obviously think wider in terms of the Marsden and a collection of different cancer pathways, but what's the best way of developing leadership and mentoring? And of course, Sajid Javid just announced a whole leadership review across the NHS and social care. But thinking about our own little part of the world, what can we do actively to encourage mentoring?
Yeah, so I don't know how, I don't know that much about how your the lung cancer's set up. Obviously, I know quite a lot of the people, but any teams can benefit from more active mentoring. I think it's not something that we've historically done that well, and that you've got very good people in the in the lung cancer community who I'm sure would be very happy to provide more formal or descriptive informal mentoring to more junior colleagues. So I think if you identify some of the senior people who you think would be good at it, and allocate for how many people they can take on and mentor. And we do it at the Institute of Cancer Research, so they match colleagues who are in a totally different sphere to me. So I'm not someone, for instance, doing prostate radiotherapy, and I'm a designated mentor for them. And we meet 3 or 4 times a year, but they also have my phone number. I'm there just as a sounding board, and the feedback is that the juniors find it extremely useful, because the mentors don't come in with any agenda about their research and no kind of preformed ideas about what they're doing, and they can give them more career advice. Also, just give them a completely neutral view of the trial idea they may be discussing. So I think that sort of thing it's quite easy to institute as well. You just have to have the people who are willing to do it.
Yeah, okay. I think that's a note for self, to see how at BTOG we might be able to support that. There was a question on Slido, sort of related. What initially led you to get a coach?
It was good. So my brother-in-law, who is nothing to do with medicine, he works in the finance industry in South Africa, and he did something similar to me. He took a big step up in an organization, and he was given a coach at the time by, this was in the private sector, and said how useful it was. And I discussed it with my CEO, and she said, realized I was taking a very big step, having not been in a leadership role before, and said, if that's what happy to try. And so she organized a coach for me. Obviously the organization had to pay for it, but I did find it extremely useful.
Okay, all right. So this morning's session was about developing your pathways, thinking about pathways, setting up services. And of course, in some ways, you've worn both hats as an oncologist leading a certain group. You're also on the receiving end as medical director, and as you said, you have to make decisions. So, as somebody receiving proposals from cancer pathways, saying that we need 10 more oncologists and 20 more radiologists and this, that, and the other, everything's rubbish. What advice would you give to a lung cancer lead who is developing proposals for investment in their service, presenting it to somebody like you? What makes your life easier?
Good point. So obviously you need to know what environment you're working in and what the financial constraints are, because that will often determine the reality of whether or not any investment is likely to go ahead. So understanding the financial environment from which you're working in is key. And then the key thing is to keep the proposal as focused as possible on what improved outcome you're aiming to deliver. So if present what is the problem, and then how you are going to deliver the improved outcome. Going in and just saying it's a rubbish service and we just need to fix it isn't really, it's not the way I would choose to approach it. I would say these are the problems, this is the proposed solution, and this is the outcome we expect to deliver. And then you go into the cost and the infrastructure and the resources you're going to need to do that. Business cases or whatever are always going to be far more likely to be successful if they're either revenue neutral or revenue generating. They can't always be. But if they're not going to be revenue generating or revenue neutral, then they need to fix a problem that is otherwise going to lead to detriments in patient safety or poor outcomes. So I think that's the way you should try and think about it.
Okay, I think that's really helpful, especially the outcomes. I mean, I don't know if you had a chance to tune in this morning, but Richard Bouton showed a slide of the lung cancer screening program and projected outcomes if an investment was made based on the stage shift from stage 3 and 4 cancers to 1 and 2 over the next decade with lung cancer screening, investing in lung cancer screening. So exactly what you just described, the outcomes of the proposed change. Okay, great. The next question I have is about horizon scanning. So presumably at the Marsden, you've got what do you call a collective of oncology or cancer pathways? So you've got a whole gaggle of oncologists. Each of them will want to improve on their pathways. You as an organisation presumably have to are planning for the future too. With lung cancer, we've seen massive gains with respect to survivorship, although it might not feel that at the moment necessarily all the time, with some of the new drugs and treatments that we have. And for some lung cancer, I hope we change it to a chronic disease. With that in mind, how do you plan at a sort of an organizational level? Because then there's so much more follow-up, so many more CTs to be done, so many more clinic spaces, so many more drugs. How do you plan that?
That's a huge question. But if I take lung as an example, so yeah, I mean, lung has been, well, in my career, I mean, although I don't treat lung cancer, it's totally transformed from when I was a registrar. Metastatic lung cancer got a 10 gray single fraction really, and occasionally a bit of platinum-based chemotherapy, which didn't work very well. And now, we patients who are coming into our medical oncology clinics, and they're there 5 years later, having presented with metastatic disease, and the disease is controlled. It has been totally transformative. So, and that that has happened largely by targeted therapies, and so if we brought that concept out, it's about personalizing all of the aspects we do, from early diagnosis to targeted treatments, and that's the way we're thinking at the Marsden. So it's sort of the smarter kind of treatment. So not just molecular targeted drugs, but better surgery, better radiotherapy, more stereotactic radiotherapy. All of these together are about individualizing the care of each patient. And also, I think, enhancing technology. So looking at the way AI is going to influence this, using digital pathology, I think is going to be absolutely key. I sometimes joke with Professor Popat that, for someone like me, when we start using these molecular reports in prostate cancer, which are starting to come in, but they're nowhere near as common in lung cancer, I want the idiot's guide version. I want the paint by pictures. This is the mutation. This is the drug you give, because we're not all going to have time to become molecular experts. So we've got to deliver systems that allow us to work with these new technologies a lot more efficiently. And I think lung is, it's going to be one of the role models, because things have transformed so quickly, and we're learning so much. I mean, I think I'm right in saying now about 40% of people have a targeted mutation in lung cancer, and that's probably 35% more than it was 4 or 5 years ago. So it has moved dramatically quickly, and I think that's going to continue. But it's really, what an exciting time to be in oncology.
No, it's fantastic, but it does bring its challenges. So, for example, one of the things in our institution is the number of. It's a great problem to have. It's a first world problem. The number of follow-ups you need to do. Your oncology suite, the longevity of people, which is fantastic, then creates other things. So I think the reason I'm asking that question is for a new lung cancer lead, because the service is going to be transformed, I hope, and lung cancer becomes a chronic disease if it's not cured immediately through early detection. I imagine the paradigm and the shift in our current services are going to need to be transformed, and thinking about long-term follow-up of these patients, sequential treatments. So I'm guessing you have to do that at an organizational level, but a new lung cancer lead is going to start needing to perhaps start thinking about that now, because a lot of these things will evolve over time.
Yeah, and I think that's right. So again, though, I mean, I think you have to think intelligently about how we follow patients up. So the first thing is about, do you need a hospital-based follow-up, or can it be virtual? What's going to be the role for circulating tumor DNA, which I think is going to be huge. So where we're bringing people back for regular scanning, possibly they're going to have an exit circulating tumor DNA test, and then one at 6 and 12 months, and then you start to get a lot more confident that actually genuinely these patients aren't relapsing. So I think we have to think more intelligently about how we follow patients up, and it will be tumor site specific. And again, I think lung may be one of the ones where we can change things sooner than we might do in other pathways because of the developments at the molecular level. But what you don't want to do is to just stick with the current where you're going to bring 35 follow-up patients back to a clinic every Wednesday afternoon. I think we can already do better than that, even just using virtual technologies. We can do better than that.
Okay, brilliant. And I think finally, if somebody was starting as a lung cancer lead, what 3 things would you advise?
What 3 things would I advise? I suppose build a team around you. That's really important. You can't, you're not going to manage the service on your own. Identify where your problems are, and so you need to know in your organization, and it'll be very different in every organization, but there will be things that need improving. So you need to identify what they are, and then go into it with passion. It'll be fun, but it'll also be hard. So go for it.
Okay, brilliant. Wise words and fabulous presentation. Thanks very much. So I'm going to hope that Josie's around and we can start our next session. So Josie, welcome. So Josie Roberts is a Macmillan nurse, a lung cancer specialist nurse at Rotherham FT, and a non-medical prescriber. And you also run, I think, a communication training program, which of course is critical to us all. So Josie, you're going to talk about team working and the MDT, something that is just crucial to for our pathways and to keep everything going and to provide the best experience for our patients. So over to you, and thank you.
Thank you. Thanks, Sanjay, and thanks for inviting me to speak. So yes, I've been asked to look at team working and the MDT. I'm also a member of Lung Cancer Nursing UK and obviously represent nationally lots of nursing issues on that. No conflict of interest. So the aims we're looking at ways of optimising team working in the MDT, effective team working and improving team working. And I'm sure we're all aware that organising a functional multidisciplinary lung cancer service is a challenging yet rewarding process. But an important aspect of MDT lung cancer care is an emphasis on patient-focused care and to improve the patient journey through collaboration, communication, and the streamlining of diagnostics and treatment. So what are the benefits of MDT working? Certainly improved consistency, continuity, coordination and cost effectiveness of care. Essential that we improve communication between health professionals. We're improving clinical outcomes, increase recruitment into clinical trials, and opportunities to improve audit. But also we need to acknowledge that it's increased satisfaction and psychological well-being of patients. It provides educational opportunities for health professionals and support from a collegial environment, as well as increased job satisfaction and psychological well-being of team members. Getting it right first time also told us that it's multidisciplinary care is the cornerstone of lung cancer care, and that MDT meetings accompanied by MDT clinics on the same day is the proposed model of care that ensures close interdisciplinary collaboration to meet patients' needs. And that MDTs are an important means for discussing potential options for a patient based on all the available results, and that they should be attended by all core members and held at least once weekly. That we should have streamlining of the MDT. This should be undertaken as standard to enable us to have greater efficiency of the meeting and for patients with more complex disease to have appropriate time for decision making. This is really important, as we know, with advances in treatment and decision making for our patients. But that communication of outcomes from an MDT should be rapid and comprehensive, both to patients and to primary care and to all other relevant clinicians as necessary. So how do we achieve patient-centred care in an MDT? because I think this, as we've said, is key. And really importantly is the communication and the collaboration that goes on around that. It's about informed decision making and for these continuous assessments for our patients, for their personal outcomes. It enables us to look at advanced care planning. We can look at personal needs and beliefs and cultures. It needs to address all patients through the emergency, inpatient, outpatient, community care, and looking at personal goals. Patients need to be aware of the MDT, of its purpose, its membership, when it meets, and that their case is being or has been discussed, and that they're given the outcome within a locally agreed timeframe. All patients' views and preferences, holistic needs are presented by someone who's actually met the patient, and that a named individual at the MDT has responsibility for identifying a key worker. And a named individual has responsibility for ensuring the patient's information needs have or will be assessed, and that patients are given information consistent with their wishes on their cancer, their diagnosis, their treatment options, and this is sufficient enough to make a well-informed choice and decision on their treatment and care. But throughout all this, it's essential that this is conducted with empathy and compassion, and there's a major role of the nurse within the MDT for providing this. So what are the challenges in setting up a functional MDT? We're all aware that time commitment is essential, and attendance, that there's dedication in providing support to the MDT, that we have clear leadership, people are aware of the roles, the processes, communication throughout, and resources that are available to us. Inappropriate job planning and time management can compromise clinicians' MDT attendance. So all MDT members should have dedicated and protected time to attend the MDT and subsequent MDT clinic, and these activities should be planned appropriately. And job plans should include additional time to cover the administrative duties that arise from the MDT. As I'm sure, again, we're all aware, the MDT is not just about having that meeting weekly, but it's all the continuous preparation and input that is necessary for it to be successful. And without that being done, a series of events can create a vicious circle, and that will impact on the quality of MDT discussions. So back in 2012, we were introduced to the DREAM MDT for lung cancer, which was aspirational with 30 recommendations, which was intended to stimulate discussion among the lung cancer community on how an effective MDT can help to deliver high quality lung cancer care, again to improve outcomes for our patients. And although this was aspirational, some recommendations were already in place in some areas, but it also clearly identified the role of healthcare professionals involved in the pathway. Sorry, this one. I think what we have to also look at then was with COVID-19 and lung cancer. And this has probably been the biggest potential challenge, not just to lung cancer, but to all of us working. It affected all areas of healthcare, but the lung cancer pathway was particularly affected. To reduce the risk of COVID-19 exposure to both patients and staff, there was a general move to virtual working, including MDT meetings and patient consultations. I think we have to bear in mind the individual impact of COVID on all of us, and certainly within our trust, our lead clinician was asked to work obviously on the acute wards as respiratory physicians. They obviously had to deal with lots of the COVID. People were redeployed, nurses were redeployed, and it was difficult to actually keep this working. But I think what we really have to be clear on is the impact on the patient through COVID. The fears of attending hospital, the fears of attending for x-rays and CT scans was paramount. Patients were shielding, there have been changes to treatment, and the big impact this had on their treatment pathway, and certainly on things such as pre and rehabilitation. As we were aware, and Gert has also said, the greater use of IT will continue into the future, but a careful balance must be struck to ensure communication and support of both patients and colleagues is optimised, I think we've seen some very positives with virtual working, and it has worked well in certain areas, and people have been able to access MDTs via Teams, so we've not lost the attendance, but obviously the face-to-face has been different. And I think equally we need to embrace virtual working for patients as well. I want to speak a little bit about Rotherham, because I think this is obviously fundamental. We're a district general hospital. Rotherham's in South Yorkshire, and our cancer centre is Sheffield. Patients are referred to the Northern General Hospital for surgery, for EBUS, for PET scans, and to Weston Park Hospital for radiotherapy and chemotherapy treatments, although we do have an outreach chemotherapy service. It's a socially deprived area, and so we see lots of, obviously many cancers, but particularly lung cancer. As we know, there's around just under 48,000 new cases a year nationally, and it's a major cause of morbidity and mortality, with smoking and social deprivation being high there. And Rotherham as a town fits all those sort of categories. We have a higher than national incidence, and we have a higher than national mortality rate. But interesting, our 1 year survival, recent figures was 37% versus 36%. Our MDT is on a Thursday morning, core members attending, respiratory physicians, radiologist, histopathologist, oncologist, thoracic surgeon, lung cancer nurse specialists, palliative care, and the respiratory, oncology and thoracic surgery clinics run simultaneously on the same day. I also just wanted to comment that Rotherham was actually one of the MDTs that participated in the Opening Doors to Treatment research, which was a project which identified the impact of the lung CNS on patients accessing treatment. Really interesting project to be part of, and clearly sort of explained the importance of the role of the lung cancer nurse throughout the patient journey. So throughout we have to address the impact on communication and clinical decision making, because communication between all members of the MDT is essential to ensure patient-centred treatment decisions are made, and it's effective communication for the patient and carer, ensuring that their informed choices about treatment are based on authoritative and clear explanations of the options, that it's with holistic support and also support for carers, addressing their information and support needs, which may differ from the patient. And again, COVID and the impact this has had has been obviously paramount for all of us over the last 18 months. But also communication and collaboration outside of the MDT is essential in ensuring that the actual MDT remains efficient and streamlined. I think certainly in Rotherham, all patients for discussion must have been seen by a core member of the MDT. They're presented by the respiratory physician. But as I've said, it's the work that goes on behind the scenes of the MDT that must be acknowledged in maintaining an effective MDT discussion. The patient must remain at the heart of the discussions, and face-to-face appointments were maintained throughout COVID in Rotherham, although telephone consultations were offered. To help demonstrate this, I wanted to present a case study that we've discussed through our MDT, certainly with the pandemic, as this patient presented in February of 2020. So a chest X-ray alert was reported on was done on the 12th of February and reported. And at Rotherham, we were implementing the National Optimal Lung Cancer Pathway at that point, where the lung CNS, we receive alerted reports. We then contact the patients and invite them to the next available appointment. Our clinics run daily with our chest physicians for our one-stop clinics. So I contacted the patient, Danny, and asked him to come and see the chest physician following his recent X-ray to discuss the report in more detail. It was difficult to speak to him at the time. He was obviously upset, so I actually spoke to his daughter-in-law, but he did agree to come and see the respiratory consultant the following day to discuss the X-ray. Sorry about that image, not very good, but that was the initial X-ray that we were presented with. So this was a 71-year-old male. They'd been recently bereaved. His wife had died of metastatic breast cancer the previous week, hence the hesitation with the phone call and his upset. His performance status was 1, he's a current smoker, and past medical history of COPD. He'd actually had a resolved cough and purulent sputum, but his chest x-ray showed this nodular opacity within the left apex. He did agree to stop with us that morning to have a CT scan, which showed a 20mm spiculated left apical nodule and bilateral calcified pleural plaques. I'd like to thank my colleague Dr. Athi for supporting me with the slides as well. So he was distressed throughout the consultation. He actually didn't see the point in pursuing investigations. He felt if this was going to be a cancer, especially lung cancer, what was the point? But through the support given from myself, from the chest physician, Dr. Athi, in encouraging him to have investigations and that there was things that could obviously be done about this, he eventually agreed to stay and have further tests done. He had his respiratory function, full lung function test. They were all done in a very timely manner with the results showing, as we can see. And his PET CT scan showed intense uptake in this 90mm left apical nodule. So a clinical stage T1B N0M0 was given with a Herder score of 94%. The images of the PET scan. Discussed at the MDT in February with the clinic appointment following, and again he was supported by the respiratory physician and the surgeon all on the same day, and myself, where he did agree to have the thoracic surgery. He had a left upper lobe trisegmentectomy, removing a 32mm adenocarcinoma, PT1C, N0, M0, fully excised on the 10th of March, and was for surgical follow-up right at the height of the initial sort of pandemic as well. It was continued to be followed up, and then his chest x-ray on the 20th of August showed a new right opacity. The CT scan done in September showed a new 9mm right upper lobe nodule, a new 6mm right upper lobe nodule, and a new 3mm right upper lobe nodule. Reviewed back in respiratory clinic, PET scan was requested, which showed intense uptake in the 9mm right upper lobe nodule, showing a T1A N0 M0. Again, as the images show. So it was discussed in September 2020, where a clinical diagnosis of lung cancer was made again, and his patient's preference then was for SABR. Didn't want to have the surgery, although he'd coped well, he'd recovered well, he just didn't want to have surgery again. And he completed SABR in November. At that time, he was diagnosed with a primary squamous cell carcinoma of the skin, which affected his scalp, and he had radical radiotherapy for that, completed in November 2020 with oncology follow-up. Fortunately, Dr. Das, our clinical oncologist, treated both the lung cancer and the skin cancer. But I think, again, it makes us realise that, you know, lung cancer is not the person. They have so many other things going off in their life, and the support needed is just increases throughout. In July of this year, his CT chest showed that the previously cavitated 9mm right upper lobe nodule was more solid, with a 9mm ground glass nodule in the right apex, and a new 10mm speculated nodule in the right upper lobe. He'd had further treatment for this squamous cell carcinoma of the scalp. He had excision there. He went on to have a PET CT in August, 17th of August, which showed intense uptake in a tiny right upper lobe nodule, and a clinical diagnosis of a further right upper lobe cancer, CT1A N0 M0, was made. The images, as we can see. So again, we brought him back to MDT on the 19th of August to discuss what we do next. Was this going to be ongoing oncology review? Was it have further SABR or further surgery? But I think we have to appreciate what this chap's gone through in the 12 to 18 months of his treatment. He's lost his wife, he's had treatment for a second cancer. So the support that was needed throughout by the lung CNS, through the entire team, is essential. In September 2021, last month, he was seen both in oncology clinic and the surgical clinic, and at this time, Danny has opted for CT surveillance. He feels well, He wants to enjoy his quality of life presently. So he actually declined further treatment. And we support him with that. And I think, again, we have to obviously recognise patients' preference, what they want. So although we've got treatments available, it's essential that we support patients in what their treatment decision is at that point. He's had support from all core members of the MDT, and this has been provided throughout. And I just wanted it to demonstrate the excellent teamwork that we have and what is necessary for these patients. Throughout his holistic needs assessment, he has identified continuing psychological problems, much of it due to losing his wife, but also financial concerns, which we've been able to address through Macmillan grants. We've been able to refer to local cancer care centre, as these are now opening up again. And throughout, ongoing smoking cessation support has been provided. And that's also been very difficult for him. So obviously he was advised to stop smoking and support was provided. But when patients are going through this, obviously they will lapse and sometimes start the cigarettes again. And it's really, really important that we continue to support them to try and quit. So I just wanted that to demonstrate the importance of teamwork in the MDT, and that is key, I think, to a successful MDT. And also to remove barriers. So where they are, that we actually have discussions both inside the MDT and out of it. COVID-19 has demonstrated that this is even more paramount. It's become more difficult. But it identifies the role of the lung CNS and the MDT working, which is continuous from pre-diagnosis and throughout treatment. And the importance of supporting our patients and carers with regular telephone contact as necessary. But that, by referring to MDT colleagues, by ensuring the care and supports provided, addressing symptoms, psychological support, whilst continuing patients to remain independent and to improve or maintain performance status and quality of life has been essential throughout. And I'd just like to finish with this picture of our local MDT, obviously during COVID, a recent one. And very many thanks to the support that's been given for this. Our lead clinician, Dr. Qureshi and Dr. Athi, our thoracic surgeon, Ms. Sochi, Dr. Das, clinical oncologist, Dr. Abreri, our consultant histopathologist, and Dr. Julius, consultant radiologist, myself and MDT coordinator, Leslie. But obviously people have joined through Teams. That's a much bigger team. That's just what we had to actually reduce further, but we're now opening up more face-to-face visits, which is obviously improved, and hopefully we can continue to do that. Thank you.
Brilliant, thanks ever so much, Josie. So a few questions from me to begin with, if that's okay. With COVID and communicating to patients, what was that like?
I think that's been extremely difficult for all of us. And I think to some extent, we've always had telephone consultations. That's been a big part of our work. But to structure these more was really important. We didn't have the technology straight away. We didn't have the virtual working through iPads or laptops, so most of it's been telephone. But we were very proactive. Certainly at the beginning, we were ringing patients as much as we possibly could. Certainly when trying to encourage them to come for investigations was a big problem. I'm sure we've all seen that. But I think it's something that training is necessary for people starting in this. We need to have more training in having telephone consultations. I think particularly trying to identify with patients that they need more than that. Because invariably, you know, many people will answer the phone and will say, I'm fine, which tells us nothing really. So I think we need much more impetus on that.
Now, there'll be places across the country who are currently using video consultations. Are you using it in your neck of the woods yet?
We have. It's not fully up and running. I think we need more of that. But I think however good video consultations are, however good we improve our telephone skills and assessing patients, I think it's essential that we still have face-to-face appointments. You know, I think the clinical examination is essential, and sadly that's where things have been missed, where patients may have then been admitted with advanced or recurrent disease, simply because they've never thought to mention something that wasn't particularly bothering them at the time of that telephone call. So I think that's been important.
Okay. Now, I'm going to go to a tricky area, and I realise there's not an answer, but one of the remits of the talk was difficult colleagues. So, we all work in big teams, and I think we also I recognise anyway, sometimes it only takes one person to upset an entire team. Any advice?
Yeah. I think that's a really important question. So when I first was discussing this presentation with my colleagues, and I suppose because we have a good working relationship, but we have had difficult colleagues that we've mentioned. We've had in the past histopathologist who didn't see the point in doing further genetic testing. It's lung cancer, it's either non-small cell or small cell. So it's how you addressed that. It's very much around communication. And if there's an obstructive colleague within the MDT, I think essentially it's important that that's addressed outside of that arena prior to further MDTs by a lead clinician or whoever it is, because we shouldn't be having that. Obviously, the MDT is good for discussion. You want people to give their opinions. That's not difficult colleagues as such. But I think if you've got a colleague that's actually not performing well in MDT, that needs to be addressed and needs to be addressed much higher. What I did find very interesting talking to colleagues is that people like coming to lung MDT because it's the best one to come to, and I think that's is that an essence of how we all work so well together. But that in other MDTs, there are lots of problems. People get up and walk out. You've not got that cohesion, I suppose. So how to address that is difficult, but I think it needs to addressing by we can't ignore it. Essentially, it has to be addressed.
So I wonder if I might, because again, the purpose of today is really to help people who are leading their services, and I suppose for me, one of my reflections is peer pressure or peer behaviour. So sometimes when you've got a difficult colleague and actually everybody else in that MDT is functional, respectful of each other, then that's probably one of the better ways to bring around colleagues who are not behaving as they should and not being respectful. So I suppose leading by example, peer pressure to help individuals really work with the rest of the team is probably something that can be used. And data sometimes, if it's about poor performance, sometimes data will help that. But these are really difficult issues for a lead clinician of lung cancer pathway, let alone just an MDT meeting. But within a lung cancer pathway, there are people who don't necessarily come to the MDT meeting itself, but the lead physician may have to deal with, and sometimes these people may not have a whole lot of experience. So I think that one of the things from the previous talk that Nicholas Fanaz talked about was phoning a friend. It often feels like a lonely place if you're the leader. You don't necessarily feel you have anybody to draw on. Collecting the information and the facts, triangulating information, all of these things will help, I think, manage colleagues that may be difficult, who may be having things going on that you don't know about, and actually may need support. So they may not be deliberately being difficult, as it were. So I think these are things that as an MDT we have to consider, because I think lung cancer, more than any other team, or as much as any other team, the total is greater than the sum of the parts. We can achieve much more with working together. And just something you mentioned there, Josie, about everybody loves a lung MDT. In my trust, they call the lung MDT the love MDT, because we're also, we all get on so well, and the MDT goes well as compared to other MDTs. Okay, so
I think that's important.
On the same,
sorry. I do think that's important, but I think if we're working in a functional MDT and we're aware that others are not, it's actually trying to pass on some of what we do that makes it work. And certainly, again, as a CNS working within that team, if I'm made to feel uncomfortable outside, again, of the MDT, it's like you said, approaching the person and just saying, you know, can I just ask why you thought that idea or that suggestion wasn't relevant? And what I have found sometimes is they've not even realised they've said that, or they've not realised they've said things in maybe a derogatory manner. So it's just really approaching that as well. It's having the confidence, I think, to do that, but equally passing that on to other colleagues. You know, for example, when so-and-so said that, what did you think? If nothing said, it's having the confidence to address these problems before it becomes a much bigger issue. I think that is important.
Yeah. Jeanette's just asked a question about reassuring patients. So during the height of COVID, and even now to a large extent, patients aren't necessarily always seeing that, you know, some of the follow-ups by telephone. Patients are scared of coming to hospital because of the worry of contracting COVID, but equally they don't want their care to be second best, as it were, because things aren't being picked up. How have you been able to reassure patients with those sorts of fears?
I think that's been continuous, trying to explain the safety measures that have been put in place, especially when people were fearful of coming for x-rays and CT scans. We had quite a lot of that in the beginning. But actually demonstrating that we were still functioning at the hospital, you know, that's really important, and that certainly for outpatient clinics, obviously for many patients, the only images of hospital they saw was the intensive care units, you know, the real severe COVID patients. And it's almost like they'd forgotten what was happening behind the scenes. So we've certainly been clear that, you know, our clinics are running, they're functional, they're clean, we've got social distancing in place, and as safe as they possibly can be. And I think also ensuring that patients are aware that they have got to weigh up the safety and the risks of not coming to hospital because of COVID, but the risk of having something missed by not having their scans and being assessed properly. So it was getting that message across to them, again, through communication skills and just explaining as clearly as possible to patients what was necessary.
Yeah, okay, brilliant. What about in terms of the team working? Do you do anything specifically with team building? So, you know, there's often a churn, as new members join a team, others perhaps leave. What do you do anything with team building in terms of the whole lung cancer pathway or the MDT members?
We go out for a drink and a meal.
Yeah,
that's one of the ways we do. We generally, well, we certainly did prior to COVID, and we've started. And I think we have always appreciated that actually meeting outside of work has always been beneficial. So we, certainly one of my colleagues is our social organiser, and we do regularly as much as possible, because I think that's important. You know, we're all human beings, but that's, I think that's a really good way of doing that. Team building as well is, I think it's been difficult through COVID because we've had such a strict cohort of people attending face-to-face, so junior staff have not been able to attend necessarily, where they might have had a patient on a ward. So that's been influential to some extent. So it's trying to support them out of the MDT as well. But we've had no sort of specific team building courses. It's just something that we try and do through clinics. Cake in clinic and socialising out of work, I think, is important.
I think that's a prescription, is it? That sounds really good. I think one more question from me. Well, a reflection first. I think one of the themes that has run through all of the talk so far today, whether it was Matt's this morning or yours today or yours just now, is purpose and having a common purpose. And one of the slides that you put up early on in the talk with the patient in the centre and everything else around it. And I think as a lung cancer team, we tend to feel that common purpose. And I think whether it's dealing with a difficult colleague, whether it's managing the pathway, whether it's bringing in new innovations, as long as the team has that vision and that common purpose, it helps, doesn't it, I think?
Yeah, I think that's absolutely key. I really do. And I think if you then join a team that has that, again, it establishes that that's what we're there for, and that's maintained. I totally agree.
Yeah, and then one final question is: do you feel that your management team, the sort of operational managers or the cancer manager, if there is one, do they take part regularly in MDTs or the pathway? Are they visible?
They are, if you need them, in fairness. I mean, they're there. They're not involved in the actual MDT weekly running as such, but if necessary, and they've certainly been there when we've had issues with technology, when we first started the remote teams working, so we've had access to that. And I think, again, we need to recognise their part in this running of MDTs. Yeah, they might not be visible, but if we do have a problem, then we need to know who to go to address that. But I think it's like I said, it's much more than just the core members in an MDT. It's the much wider remit, and it's important from us that we actually pass all that information on to other people that is relevant, especially if we're having problems with that.
Yeah, and I agree. And I think actually we're really lucky in my centre. We've got a fantastic lung cancer manager. And bringing them in, making them feel part of the team and being part of that common purpose has been really helpful for us. Listen, thanks ever so much, Josie. Really appreciate that. We're going to have a break now, and then we'll be back for the talk from Dave Baldwin on governance. So I hope everybody gets to have a cup of tea and do whatever you need to do. And we'll see you back here in about 15 minutes, 2:15. Thank you. And welcome back to this afternoon's session. We are very lucky to have David Baldwin with us next. David Baldwin is a consultant in respiratory medicine in Nottingham, just up the road from me. He is chair of the UK Clinical Expert Group in lung cancer. He's been a big driver and proponent of the lung cancer screening programme, and of course has worked on many guidelines related to lung cancer. Now, as a new lung cancer lead, it's probably one of the areas that people may not be aware of, and that is governance and how to deal with the governance within the service, especially with new services coming on stream. So, David, over to you, your talk on governance.
Brilliant. Thanks very much indeed, Sanjay. And thanks for asking me to sort of tackle this topic, which can sometimes bring back memories of maybe less favourable job interviews where you've been asked about the pillars of clinical governance. These are my conflicts. I'm just going to try to discuss how to run a service which is effective and safe by using the various tools that are available through the clinical governance process. So, as I'm sure people that have been through job interviews or preparing for job interviews will remember, there's often a governance question that you have to prepare for. And I have to say, it comes over a bit dry in job interviews, but actually in the real world, these pillars of governance that are listed here or similar ones are actually tools that you can use to make sure that you design and run a service very effectively. And you can see they're all listed there, and they are very much interlinked. One thing does not stand alone. It's sort of almost artificial separating, but also quite useful. So I'm going to try to go through these and illustrate some of the ways in which the pathways can be developed and implemented as a result of the governance process, and then ensure that they're safe. So first of all, clinical effectiveness and research. Well, research really should underpin most of what we do. In reality, it often doesn't. It certainly does drive some clinical practice, and guidelines now are increasingly very carefully constructed so that they're evidence-based, such that sometimes you will have recommendations that aren't based on evidence because the evidence itself that you thought was quite good, in fact, doesn't stand up. So these are very useful. And we have then this linking in with clinical effectiveness, because this is essentially trying to define the best outcomes for patients
and we have national guidelines that can be locally implemented, which will ensure clinical effectiveness because they're evidence-based. We have national service frameworks which enable you to implement the guidelines and the best practice. And then you need to develop local tested protocols where needed, but only when they're needed and not when there is a national guidance that might say otherwise. And we sometimes see this, that people go in their own way without looking at the national guidance. So what I'll try and do here is illustrate where we have developed a national framework, which is the National Optimal Lung Cancer Pathway, and how this is used with the tools that we have in the governance process to achieve what we want to achieve. And the objectives, of course, are to accelerate, standardize, and optimize to reduce unwarranted variation and reduce some of the things that we see in the lung cancer world which is not favorable, such as emergency admission rates and the very poor compliance with waiting times targets. And then we also want to improve efficiency by better processes and improve the outcomes, i.e. the clinical effectiveness and the patient experience. Let's wait for it to reconnect. Oh, that's great, thank you. So this is one of the slides that you probably see frequently, the National Optimal Lung Cancer Pathway, a pathway on a single page but with lots of detail. And you can see that, for example, this first part of the pathway originally is really an evidence base, and only subsequently have we supported the evidence through randomized controlled trials. So sometimes the research follows the pathway rather than the pathway following the research. It's a framework, and the pathway has become slowly more detailed. So now we have these diagnostic standards of care which are aimed to point people in the right direction to standardize the way we do things. So further attention to trying to standardize and optimize what we do. And this is one of the diagnostic standards of care which gives pretty specific ideas and instructions as to what one should do according to what the apparent stage of the cancer is on the initial CT scan. And very, very helpful, I think, to many units, especially people that maybe are starting out and trying to get the most efficient service. And then we have targets and best practice. So here, there's one of the time treatment pathways, which was developed by a number of experts in the area, giving the maximum waiting times on the left-hand side, referring to the National Optimal Pathway position, but also a number of best practice pointers, which is another way that you can improve services. How many of these best practice pointers may well help in your service? So these are all frameworks. Once you've done something, or you're about to do something, then a good idea is to do an audit. And these are available from the point of view of national audits, which are very useful at looking at an overview, for example, variation in what we do, but also local data is often applied from the national audit. And the issue there is this a true reflection of what's actually happening? And we know from the National Lung Cancer Audit that occasionally people will, in actual fact, we don't recognise what's happening in our trust in the reflection of the national figures. And this is where you need to do a local audit, where you've got much better control of your data quality. And there you can really identify what's going on. And sometimes there are some surprises from that. Now, we have a lot of data in the UK. We're really lucky, actually, in a sense, that we have such good data. We have the National Cancer Registration Analysis Service, which includes the clinical data set on diagnostics and general clinical features of patients, the cancer outcomes and services data set, as well as the linked SAT data, an imaging data set and radiotherapy data set, and of course the National Lung Cancer Audit, which is also been incredible in the last 10 years, and I'm sure will be in the future. And finally, some primary care data sets, particularly the Clinical Practice Research Data Link, which can be very useful. The way these are used currently in the process of governance specifically is essentially through the Cancer Alliance service. So there's a specific data analysis group that work with the cancer analysis called CADIUS, and they produce Cancer Alliance dashboards which can enable you to drill down by CCG, by trust, by all sorts of different filters to analyze your own service and benchmark it against other services. And of course, it's used quite extensively, often outside of our clinical services, by integrated care systems managers and administrators, and used as comparator figures for different trusts, and regional medical directors use this quite a bit as well. Then we have the National Lung Cancer Audit, which produces some very useful annual reports and spotlight audits and sets the top targets, which are very relevant to improving lung cancer outcomes. The National Lung Cancer Audit has revealed huge unwarranted variation across the patch in the lung cancer world. This is just one figure looking at the variation in curative intent treatment by CCG of residents at the time, showing really quite marked variation. And then we have this piece of work that was done in Nottingham, showing that if you're first referred to a surgical centre for your lung cancer, you're much more likely to have surgery for that cancer, having control for a whole variety of different other factors that could extend that problem, showing the same thing a few years later. So another pillar or tool clinical governance is risk management, and this means having robust systems which enable you to understand, monitor and minimise the risk to patients and staff, and to learn from the mistakes. It includes following, as we've already discussed, protocols which come out of the guidelines, incident reporting, analysis of error and complaints, and it includes breach analysis, for example, in the cancer pathway, particularly focusing on patients who have long waiting times. And finally, where we might have identified a systematic process of risk creation. So from the point of view of path analysis, this is essentially looking at the pathway as a whole and looking at the time for each. And we look to identify whether the breach is preference or avoidable. Is this a recurring problem? And then we also want to look at the harms as a result of this process. Has there been a stage shift, a change in treatment as a result of this delay, or an adverse outcome that's clearly identifiable? And it's really helpful in these instances to have a standard, for example, the pathway, which gives you something to benchmark against. And it runs well. It is really easy to audit. A case that did go rather well, very, very rapid initial diagnosis, and a respective progress to VATS lobectomy. But the key thing here was that the pathway was bundling of tests and rapid pre-booking of areas required. Risk ready to come out, as I said, where you've got a systematic problem that you've identified. It may be something that's existing, or it's something that's anticipated. And here we want to define likelihood this problem is going to occur in the future or has occurred, and the severity of the problem, what mitigation might be appropriate, and a timeline and responsibilities to implement those mitigations. It's very useful to identify something that requires an extra resource and therefore should be prioritising the funding stream that operate in the various NHS. It is often quite daunting, which appear to be rather subjective in the way they would, but it is when you've got a problem. Educating is obviously underpins all of this. If you don't know about the guidelines, if you don't know about the relative research, and if you don't know audit results, then you're not going to be all that equipped to lead and manage and improve a service. So all of these things here are important, and I think local meetings in particular are often neglected, and they're very important for a variety of reasons, including updating and making sure everybody understands where they're coming from. And of course, the appraisal process is something about personal, but it does link into this whole process of how well and adequately you're trained. Patient can take a variety of different forms, but local surveys are extremely useful. There's regular national surveys, particularly in the cancer world, the National Cancer Patient Experience Survey. Local hospitals can have patient groups which can provide some very, very important feedback and also support for change where necessary. And then, of course, there's individual fees, always very, very important. So I always try to show this slide, which I'm sure Matt is delighted with, which I think is excellent, a typical example of how to support a pathway through a short and sharp patient survey. So supporting a rapid pathway, what you do is you send a survey and say, given your GP wondered about the possibility of cancer, how long would you wait to complete investigations? And the vast majority, it's less than 2 weeks, which is well short of the 28-day diagnostic standard that we've just introduced. So it just shows you the patient's expectations are. In our hospital, university hospitals, the local implementation of NOL took a very serious and well-structured process through the Better for You system in the hospital at the time. We had 5 work streams. There was a systematic approach to all parts of the pathway and leads in those areas. There were analyses of the 62-day breaches and discovery meetings, demand and capacity analyses and process mapping, as well as audits, benchmarking exercises. All these are very important if you're going to take this very seriously, and all under the umbrella of development and one of the tools of governance. Information, another pillar, and data, as we've seen, as I'm sure I've convinced you already, are incredibly important, but they have to be relatively accurate and they have to be complete. And that's about making sure we do record data fully, which is not always the case. We then understand how it can be used and also how it can be abused and misinterpreted. And of course, if it's individual data, we mustn't forget that it has to remain confidential. So we've talked about, I know earlier on there's been a talk about leadership, and we touched on management of the team with Jodie in the last talk. I think this is incredibly important. It's one of the pillars of governance, and it's about staff and staffing. And if you're going to have a really effective service, if it's going to be safe, then you have to have they've been well developed, they're involved in the delivery of what you're doing. They should have good working conditions, not always the case, and they should have good resources, which is not always the case. You have to foster the positive relationships and deal with the less positive ones. Identify areas of need service which will impact on the individuals, but also in the individuals themselves through the appraisal process. And above all, encourage openness and willingness to speak up openly as a team member if there are concerns. I was asked just to briefly cover the targeted lung health check and what we tried to do in the context of this process. I think, to be fair, the sudden decision to spend so much money on this process was a shock to everyone, not least me, and it induced panic because I realised that we hadn't actually got the processes in place to make sure this was, or to try to make sure that this was going to be a well-run programme. And therefore, pretty quickly, a standard protocol was written, not a guideline, but a protocol, and followed up by a quality assurance standard, which covers most of what I've talked about in this talk on governance, as well as a lot of other specific factors. And lastly, I'd like to mention briefly the peer review process, which, having been in this field quite a long time, I've seen the peer review process make a tremendous difference to cancer services in general and also in lung cancer services. It was originally developed as an idea in the National Cancer Plan of 2000 and began shortly after that. And initially, it was an extensive review of services and then downgraded to largely internal reviews, which is what it is now, except for particularly troubled sites. And it initially helped to set up the infrastructure of the hub and spoke model particularly giving extra resources to areas that had poor resources. And then there's the GIRFS process, of course, which is not cancer specific, but it does target specific topics. And the lung cancer GIRF process is partway through, with BTOG being one of the leads of this. And it has considerable power to change services through its links with the CQC. So in summary, the pillar is a set of tools used, and that's how you should see them. They're interlinked and often overlap. Having a systematic approach to governance is essential and ensures, I think, the development of systems and people, if it's done properly, measurement of outcomes, service improvement, mitigation of harms, and probably the most importantly, inclusivity of professionals and patients. Thank you.
Thanks very much for that, David. So we've got a question from Jeanette, and it's a question around different types of audit committees. So in NHS governance, audit committees differ from clinical audit, and they focus on financial variance, performance and use of resources. Do you have a feel for where this is looked at with respect to lung cancer?
Right, so it's quite a difficult one. Thanks very much for that, Jeanette. I think so with regards to financial audits, one has to understand that the benchmarks are often set against other interventions, and that is the key problem, as far as I can see, with regards to the benchmarking of financial tariffs, etc., is a real minefield. If you take the efficacy, for example, of smoking cessation and the way it's measured, then most people that are auditing and deciding on financial priorities will then say, well, just do smoking cessation, irrespective of the incremental amount of money you might need to spend to make smoking cessation more and more effective. Now, no one will want to argue against smoking cessation, but you can't shelve another service as a result of that. You have to accept that you spend more. So part of the problem with the financial process, as I see, is that I'm up against this argument where you're, an ICS, for example, it's ICS now, isn't it? The modern world is sort of the ICS is. They're making these decisions on the different choices, and the most effective people will put themselves in a silo and compare like with like, and then make a decision on that. So you might be saying, is it worth investing in a new LINAC in this particular area, and therefore make us have a better capacity for advanced radiotherapy, or is it better to just make the other centre work harder, for example? And that will go through a process of the assessment of the feasibility of the whole thing, and the audit of current practice to see where the problems are. And if there is a problem, then, and the mitigation is to have a new LINAC, then that's what they'll fund, but it'll be at a cost, and then it will be in competition with all of the other things that they've got to fund. So I think I'm much more comfortable with a clinical audit, being able to look at a clinical audit and say, this is what we see as a problem, and this is what we see as a significant source of variation, and this could cause harm, etc. So that's you do your audit cycle, and then you suggest a mitigation, and then you see whether that has improved. I'm happy with the clinical side. I have a real problem understanding the process and managing it actually through the financial process. And I had nothing at all to do with the Targeted on Health Check programme financial considerations on a national level, and the same with the National Optimal Lung Cancer Pathway. All I heard were the problems about capacity and difficulties and finances and huge cost, but other people sorted that one out, and I'm so glad they did. Very, very difficult. I mean, Jeanette sits on a CCG and now an ICS, so she's well aware of all these type of arguments that come out, and I think it's really, really difficult when you do that.
And I think sometimes for clinicians, as it were, who are on the front line or removed from those discussions, you can sometimes not understand what's going on at those levels and the decisions that have been made, and the false decisions, if you like, almost. So it can be frustrating. And the whole purpose of today is to help new people or people in leadership positions within lung cancer and the next generation of people. So this is an area where I think understanding how financial decisions are made, how services are commissioned or not commissioned or decommissioned is going to be really important. And it's a skill set that maybe as a lung cancer community, we need to help develop for our leaders and our future leaders to make the financial arguments. But I'll put that aside for the moment. My next question to you, David, was going to be, again, somebody coming into the job as a new thing, where should they look for potential governance problems? What are the classic areas do you feel that there may be, if there are themes, is there somewhere they should look because there might be a problem that they just don't know, it's not been brought to their attention?
Well, I mean, if you're unsure about where to start, I mean, the first thing to do is to use the frameworks, as I've already alluded to. We're quite lucky in lung cancer because we do have these frameworks that are set out. The peer review process was an area where we had these frameworks were there. You had a series of things that had been carefully developed for the cases, and your job was to see how compliant on these things. And then, of course, all of the tools, the pillars of clinical governance, that you try to fix the problem. And you can look at a problem. So say, let's for example, you have a problem with your problem. You're not getting immediate CT scans. The radiologist is saying scans for at least 2 weeks. This is going to be the waiting time, and we can't because we radiographer scanners. We've got too few radiologists. Disaster. If we give you treatment, then we'd have to give everybody else special treatment. That's a real problem. That's a very common problem. So what do you do with that? Well, first of all, you say, well, what are the national standards? What is everybody else doing? How do they do it? And you then have to go through a whole change management process by bringing together the team, and you use your difference of your leadership skills, your team working skills, all of which have been discussed today, and you tackle the problem head on by making sure, saying, well, this is the standard, this is what we have to achieve, how are we going to do this, and then come up with some good ideas about how this is done. And also then show through a process of logical argument how this can work. In other words, say with the CT scan at some point, that's a common argument, isn't it? And so you move on and do them straight away. And the only issue, and you have to acknowledge this, is the peaks and troughs. As you make things more and more urgent, you're going to get higher peaks and lower troughs, as it were, because of the very short time frames. And it's a very, very slow process, really slow process that go through. Some centres achieve it very, very. It's often led by individuals. So the whole point fostering positive relations. You get one person who wants to do something. Transforms had later the first time have a good patient so long radiologist that decided this was a good thing, and then we all for her too. So that can be, if it's a systematic problem. So at the moment, for example, in Nottingham, we've got an issue with the targeted lung health check pilot, which we're now going through the arguments that we just can't cope with this. We're starting there. It's just the same argument as the CT scan problem that we've got. Confident we'll get there. To be a process of management and logical argument, and then seeing what we were doing, reviewing it, developing a new, potentially a slightly modified pathway and a framework for people, making sure they stick to targets, make sure everybody's happy, feel positive about things, enjoy what they're doing, and feel they're doing a good job. That's all about this is very, very important. I think, Jodie's comments about teamwork and making sure you're all a happy team, and your comments about the love MDT, I have to say, I think that's probably something you shouldn't say in public. But anyway, it's great, isn't it? It's what makes you're happy every day. You go home happy because you've got a team, and I think that's one of the most important things in governance, actually.
Yeah. Can I just clarify that there's no impropriety suggested with it being called the Love MDT? But anyway, right, Jeanette's got another question. So the NLCA shows variation in outcomes and services annually. Where are actions taken by each trust to mitigate or measure the change impact before the next NLCA?
That's a very good question. The way the LCA work is that they identify outliers, and the is able to send an LCA report in any case, and that's often used in the review process. But when you're an outlier, you have a letter is written to you to warn you, first of all, as you've been identified as an outlier, give you a time to reset, and a warning that to be sent to your which is what happens. So the letter that goes to the chief executive means then that you require an action. And normally speaking, your problem, the audit figures usually a year or two out of date anyway, so I've already mitigated the problem. And it's very useful because it does give you something it's there, and the trust are not happy if you're an outlier. So it's one of the ways in which you can get more lung cancer nurses, or you can improve your times, etc., and improve your rates, etc. That is quite helpful. How is it done? It depends on what's been identified. So in our case, we had a persistent problem with the number of people that had been seen by a lung cancer nurse specialist. Are now equivalent to from 5.8 to 1.8 in the course of 3 years. So not surprisingly, we had an result of that unfavourable audit result and incredible efforts on behalf of our lung cancer lead at the time and the nursing lead. We dramatically increased the number of lung cancer nurses, and it was mitigated. If it's a different problem, if you've got more of a multifactorial problem that could be influencing that, and it requires a sort of more of a complete pathway review to do it, and then to check. And first thing you do is you check your data to see whether it's actually correct or not, and then you take it from there.
Okay, brilliant. Listen, David, thanks ever so much. That's really insightful, really helpful. And again, for people who are taking on these positions, I think a lot of what you said will be really helpful for them. So thanks very much. So I'm going to move on now to the final session, which is me, actually, and then we're going to have a Q&A at the end. So I was going to start with just summing up and some of the things that I've taken away from today. So we started off the day with Matt Evison talking about what a lung cancer service should look like or could be like in 2021, and basing it on what he and the team have done in Manchester. And some of the things that I took away was that breaking it down into different areas, whether it was prevention, and they worked on the smoking cessation, early diagnosis, and the things that you can improve there with a whole rapid pathway. Didn't even cover lung screening because we didn't have that time today. The staging part of the process, etc., and developing protocols for each of those and striving to do the best possible job. And I think the thing that came through from Matt's talk for me again was about that common purpose and vision, collecting data, and really thinking through problems with all of the stakeholders. So in his particular patch with the Cancer Alliance, thinking about how do you not disadvantage people with, for example, EBUS waiting times by having a common EBUS referral system, sounded really good, although obviously giving a few headaches here and there. So I thought that was really a really useful conversation to anybody running a lung cancer service, striving for excellence. You're not going to go too far wrong if you can manage some of the things that they managed to achieve in Manchester. Second talk was Liz Toy, and the thing that really struck me about what Liz said was using benchmarking to drive improvement. It's not using benchmarking to be scared or to whip yourself, but to think about how you can use that information positively. And in some ways that also came through there with David's talk on governance, but looking for the unwarranted variation, asking the questions about why that might be that you have unwarranted variation, assuming it's negative, that is, you might have positive unwarranted variation, and using that data to make change, to again get a common sense of purpose between you and your colleagues to drive that change. The third talk with Richard Bouton was again really insightful, and in some ways he charted the way in which Manchester transformed their services. And I think a few things that he said really struck me. So one of the things he said was, when he reflected on the pathway when they started as a team, was, this is crap. They were willing and not scared of saying, well, actually, we could do much better than this. Where we are at the moment isn't great. We need to do more. And this is causing patient harm. And he and the team in Manchester use that to galvanize the team, the multidisciplinary team, all the stakeholders, to come up with solutions, a common vision, and then make business cases using the data that they gathered meticulously to drive that change. And the other thing that he said that really struck me, he was quoting somebody else, but he said, patients wait for capacity, but actually you need capacity to wait for patients. And I think I definitely most of us are probably in a position where our patients wait for NHS capacity, but we need to turn that paradigm around. The first session of this afternoon, the things I took away from Dr. Nicholas Van As, who's the medical director at the Royal Marsden, was his journey of leadership. And he, I think, pretty eloquently talked about imposter syndrome, about needing help when he started up, needing to think about where he was going to get help from, so phone a friend, that some of the decisions that you have to make, they're not always going to be right, but you need to make decisions, and being brave but fair with decision making. And it can feel lonely at times, and that's why it's really important to have friends that you can rely on and go to for support. And I think the other thing that came through for me with Richard's talk was the passion, actually. And I think he said that he really enjoys research, and that's one of the things that he's really held on to doing his job, and that's helped keep the interest up and the passion up for improving services. The next talk we had was from Josie, one of our lung cancer nurse specialist leads, and we considered the issue of team working and having a cohesive team, a team that enjoys doing what they're doing, keeping patients front and center, and again developing that common vision and purpose with colleagues in the MDT, having a well-functioning MDT. And if you have colleagues that are having a difficult time or being difficult, working out why that might be the case and supporting them, and using that common purpose to hopefully change behaviour and make the lung MDT even better. And then the talk from David just now was all about governance, and David talked about using the frameworks and the protocols that are already out there. There are several of them. There are several national data sets, and using those frameworks and protocols to think about where your service is, where there might be gaps in governance, where there might be improvements to be made. So for me, there was lots of stuff today that was really thought-provoking and useful. So I wanted to just consider the future. And if I could have the next slide, please. Can I have the next slide, please? Thank you. Oh, no conflicts of interest. There you go. So this is one of the quotes that I found that I thought was really relevant to today. So if you're leading your lung cancer service at the moment, or you're thinking about it in the future, what you do, the future will depend on what you do today. And I think there's quite a lot of groundwork for us all to do in our lung cancer pathway, in our lung cancer MDT. And thinking this through, if I could have the next slide, please. There's quite a few things in some broad areas that I was just going to cover. But I first wanted to say is that for those of you who are leading your lung cancer pathway, it doesn't have to be lonely in case that's how you feel. So at BTOG, we're a broad church. One of the things I love about the BTOG work is that it's multidisciplinary. We have oncologists, we have radiologists, we have nurses, we have doctors in training. All sorts of people are members of BTOG, and all of those members will have been through a lot of the things that new people might be facing, where it might be daunting, and we can network and use that shared experience from within BTOG to support new leaders in this field, and it's very easy to reach out. The whole is greater than the sum of the parts, for sure. So your particular lung cancer team, it's that collective that's going to get you over the line, and certainly with BTOG we have that. The other thing I thought was worth just mentioning is the 25 by 25. This is the UK Lung Cancer Coalition, and the report that was released almost 5 years ago now, striving for a survival of 25% by 2025. Unfortunately, that looks like that target looks at significant risk, pushed back in part by COVID. But hopefully we will get there, and hopefully we will, in fact, in the next decade or 15, 20 years, considerably change that target. So what are the things that might be coming along that a lung cancer lead today may need to think about? Well, with respect to prevention, Matt talked about it this morning, and that's embedding smoking cessation services within lung cancer pathways. I think we need to do this at scale across the board, and this will complement work going on nationally to provide smoking cessation treatment in hospital. So the current national prevalence is about 14%. We're hoping to get that down to less than 5% by 2030. Although the likelihood is we'll miss that target. However, with a drop in lung cancer prevalence, it will most likely change the typing of lung cancer patients coming through, probably more adenocarcinomas than small cell and squamous. With respect to screening, the fantastic work of the lung cancer screening program with CT scans is already here. It's likely to increase. So you may not be a lung cancer screening centre at the moment, but you might be in 5 years from now or 10 years from now. You may need to incorporate patients going through screening programs into your service. It may mean additional theatre lists, for example, additional CTs follow-up. So lots of things in the screening world that may affect a service in the next 5 or 10 years. One of the really exciting things on the horizon is the Gallieri test, the blood test that you may have heard Amanda Pritchard, the new CEO of the NHS, talking about. And that's a blood test that may identify up to 50 different cancers at a much earlier stage. The target is to have a stage shift and have 75% of all cancers being diagnosed as stage 1 or 2 cancers. And we're a long way from that at the moment, but it may be that in the next 10 or 15 years, we're closer to that target. So lung cancer screening, whether by CT or blood test, how that's going to impact your service, what that will mean, is something that maybe we should start thinking about. Diagnosis that are rapid and much more individualized, again, is already here. So Matt and the Manchester team have done a fantastic way of doing this, but we know that we're far from having a uniform picture with rapid diagnosis across the country. The individualized molecular phenotyping of patients has again come on leaps and bounds over the last few years. It's likely to develop much further. How is your service going to deal with that explosion of new mutations and new potential treatments, as well as perhaps thinking about lung cancer as a chronic disease and retesting people with the passage of time? New things with respect to treatment, again, they're already here. When I talk to medical students now, I talk to them as perhaps lung cancer being a chronic disease and managing a chronic disease, as we have done, for example, with HIV. And hopefully lung cancer will be similar. How are different services going to manage that? One of the things that we're struggling with perhaps locally is that our follow-up clinics are much larger, and they're expanding and they're expanding and they're expanding. So how do we manage that? How do we manage that with our workforce? How do we manage that with our communications, using perhaps virtual communication and clinic appointments more, whilst keeping the quality as similar to a face-to-face appointment? Survivorship. So with the improvements in the lung cancer pathway, survivorship, hopefully we'll see a much greater cohort of people surviving lung cancer. And how do we measure, how do we improve their holistic care? Do we routinely talk about reducing the risk of heart attacks, for example, in our lung cancer patients? Should we be doing much more with respect to that holistic care around survivorship and looking at other medical problems that our patients present to us with through the lung cancer pathway? One of the things that we didn't probably have sufficient time to talk about today, and maybe this is a webinar in of itself, is workforce. Across the NHS, we're short of probably at least 100,000, maybe 200,000 staff. A percentage of that is within the cancer pathways, from radiographers, nurses, doctors, pharmacists, whoever it may be, and this problem isn't going to go away. So how do we adapt our services, assuming that the workforce problem may be chronic? Do we use extended role practitioners? Do we have cancer practitioners that may be doctor and nurses, or nurses that can extend across diagnosis and treatment? How are we going to manage workforce? Because the probability is this is our problem to manage. We're not going to be rescued by somebody else. Not in this slide, with respect to where we, looking at the horizon scanning, is the role of research. We've seen with COVID how patients can be enrolled in research rapidly, and we can have really pragmatic trials done very quickly, which impact on service and interventions. How can we utilize that paradigm from COVID and have it in cancer across diagnosis and treatment? How do we increase our use of research? How do we treat advanced disease? And it's certainly likely that as we become adept at diagnosing cancers earlier, that we will also become better at treating advanced disease. So, at the moment it's primarily oligometastatic disease, but it may be that we get the opportunity to treat metastases in several areas, and that may be a development for our services. So there's lots of fantastic things that we're going to be able to do, I hope, in 10 years. I reflected today, before today's talk, that When I first started doing lung cancer, we were using physical films. PET scans were not used at the time. There was not necessarily a cancer MDT. There were no targeted therapies. And so we've come a long way in the last 15, 20 years, and we're likely to go a lot further. And actually what we do today, what we plan today, will help us achieve those goals. So I think I'm going to stop there, and hopefully there might be one or two questions in Slido. And also I wanted to bring back Matt and any of the other speakers who may still be with us to be able to take questions. I think we have a great community, don't we? As demonstrated by today's webinar, we have a great community that does want to improve the service. We've moved away from the nihilistic views, I hope, about lung cancer, and we're now in a phase where actually people are really excited about looking after people with lung cancer, improving services. There are lots of trailblazers, and it's really exciting, I think, being a lung cancer lead. So Matt, I didn't get a chance to ask you this question this morning. So obviously you're not exactly old, but if you were new in post, a new consultant in post, leading a lung cancer service, what advice might you give to somebody starting out? And I think, Matt, you said there's a lot of gains to be made at the front end, and it can feel quite overwhelming at first, but if you want to start somewhere, there's probably some big wins to be made at the front end. Is that about right?
Yeah, definitely. That process of getting someone in a CT scanner that's reported and in front of a clinician who knows what they're doing, you sort that bit out, you'll take weeks out of the pathway in one go. I do think the next bit of that is that the responsibility of the rest of the pathway can't lie with an individual hospital lung cancer team. It's going to be regional solutions and collaborative solutions. And I think that's kind of what we've seen in the way we've approached things.
So I've got two other questions related to that. So the first question is the cancer alliances. And actually today we didn't necessarily have anybody specifically talking about cancer alliances, but clearly you guys have had a really good experience of the Cancer Alliance. I think they pump primed the Cure program, and they pump primed Rapid as well. And so how do we share the information of what Cancer Alliances are doing? Because it might be that we can, kind of say, well, the Cancer Alliance in Manchester did this for Manchester. What do you guys? How can you help us here? How do we utilize? How do we garner that?
Getting the word out. I think I completely agree with you. It's one of the reasons I wanted to work within the Cancer Alliance. They have always placed significant importance on the pathway board. So they've got 25 different cancer pathway boards. So all the major cancers, but equally they've got a young adults, a teenager and young adults cancer board. They really do put a lot of emphasis on the value of those boards, and they fought really hard for pathway board directors to have paid time and have PAs to deliver that job. And the other thing that they've done is which I think is quite unique, when transformation funding will often go into pathway work, their biggest lung investment was in prehab for cancer and cure. And that is really quite unique, and something that I think they should be very proud of. I think, and they're even talking now about how, as ICS systems come in, how does the Cancer Alliance truly become the cancer arm of the new ICSs? Because the pathway boards, they're really clinically led. And so you can think about standards and models, but to enact that's the massive challenge. I don't think anywhere's truly addressed that, where an alliance has real power in terms of operational, financial, and strategic direction. For Greater Manchester, that's the discussion at the table at the moment. How do you do that? And I think it's an exciting time, and I think Cancer Alliances have they're going to be a massive vehicle if we're truly going to do great things.
So that might be something for us at BTOG to think about for future conferences, maybe, or webinars, I think.
Yeah.
And then I think next question is related to planning now, today, for 10 years from now. So in my little bit at the end there, I was thinking about the future, the 50 cancer blood tests, the circulating DNA, the lung cancer as a chronic disease, the preventing heart attacks in lung cancer patients, all the things that maybe we're not thinking about just now, but we're going to need to prepare for. Have you had a chance to think about some of this?
Yeah, all the time. You can imagine working with Richard. It's a constant discussion. I guess the biggest thing for us is lung health checks on a regional scale, and we've spent 2 or 3 years trying to plan what it would take to do that. And Richard kind of gave a snapshot of the scale of it, and that's just one region. There's about 500,000 people that would be eligible in Greater Manchester for a lung health check. We do about 500 surgeries a year at our hospital, and we probably add in about 800 to 900 a year from rolling out a program. You're talking about double, tripling the volume of work, and the solutions to that are quite mind blowing. But if we're going to do it, it has to be something that has the economy of scale and resilience and sustainability to deliver services of that size, which are going to be a massive infrastructure investment. Those solutions could be loads of different things, about community diagnostic hubs and new diagnostic hubs, centers, but whatever it is, it has to have the economies of scale to deliver that. And again, I think these are regional solutions. And again, brings that Cancer Alliance operational, strategic, financial oversight with actual power to enact that. It's the size of the challenge in front of us is just mind blowing, but the opportunity in front of us is equally mind blowing. We've not seen, despite everybody's efforts, everything we've talked about, 62-day performance has gone down. COVID has put us back 10 years. It's, you're balancing it's sobering, but yet the opportunity, there is something that we've never really had before with the lung health check programs. We could do something amazing if it's rolled out well and in the right way. And that's the next 10 years.
It's very exciting. So I think, David, hello, you're back. Good. I think it's 3:15, and I think it's time to close out the day. David, did you have any last thoughts or comments actually before I close up?
So I just think that one of the things that we have not fixed is the variation in clinical practice, and we cannot keep ignoring this, but we are. And I don't think we'll ever balance the system so that we have the same facilities and expertise and time for patients wherever they're first referred. And I don't think it's a solution to move everybody to big centres. So I think we've got to try to think about how we can combine our services so that instead of we're just doing our own patients, we're actually doing everybody's patients, if you like. And, certainly with the targeted lung health check, we're planning very hard now about what it's going to look like when it's a national system. And that the discussions about national radiology reporting and national this, national the other, are the ones that are obviously more likely to become a solution. So, if we do have a nationally sanctioned program, it will look very different. And, it is a big challenge, but the breast cancer screening program is a huge challenge. So is the colorectal screening program, and they're doing pretty well. So I'm less pessimistic, realize the challenges, but also realise that we do need, the next generation of leads need to tackle this problem of the variation in the clinical presentation of lung cancer and how it's managed, and I don't think we're there yet. We tried with the service guidance that was produced by the CEG, and we'll continue to try with that. But I think it's the next generation, you guys basically, and people younger than you who are going to be doing this and getting it right, hopefully.
Brilliant.
I'm confident.
All right, listen. Thanks very much. Thanks very much, David. Thanks very much, Matt. Thanks to Dawn and Gina, and to all of our speakers today. It's been a really interesting day. I think it's also generated a lot of ideas for us, hopefully, at BTOG to support leadership in lung cancer and all the leaders that we have embedded in our programs across the country. It's a really exciting time. And I hope to see you all at BTOG 2022. Thank you.